Combining our statewide platform of health professions education program, Big Ten biomedical research infrastructure, national name recognition, and the reputation of Rutgers University, with this historic collaboration with RWJ-Barnabas Health, creates the fertile ground we need to grow an academic health center of truly national caliber. This morning, we're going to hear from a national expert outlining the core challenges facing our healthcare system that will impact how we educate our students, practice in our clinics, and the care we provide to our patients. Later on, we'll discuss these challenges and how we, as the state's premier academic health system, can have a meaningful impact in addressing these problems for our patients and for society. Lastly, we hear from our Rutgers and RWJ-Barnabas colleagues about one of these key areas, our aging population, this afternoon. In the near future, in other sessions, we'll be jointly hosting other symposium events to address cancer, global health, and mental health, all areas of strength within our BHS and all areas of major strength and importance to our healthcare system. With these set of symposia, today opening and then the following symposia to come, we are celebrating this partnership, celebrating in the way academic centers celebrate things with an academic symposium. So next, it's my pleasure to introduce the president of Rutgers University, Bob Barchi. Through President Barchi's efforts 5 years ago, we brought to fruition the creation of Rutgers Biomedical and Health Sciences, and the creation of my job, too, so thank you. And thanks to his support, we were able to consummate our public-private partnership with RWJ-Barnabas, creating one of the largest academic health systems in the country. So it's my pleasure to introduce to you Robert Barchi. Bob?
Well, this is something of a record here. Brian and I have 5 minutes between us. And of course, either one of us could take an hour, but it always is daunting to follow Brian because, as they say, he says it all. And he did say it all this morning. I want to echo his words of sober sadness, though, about the events at the Tree of Life, and just mention to you, if you don't know it, that the rabbi there is a Rutgers alum. So we have a special connection there. But we have a special connection to each of these events that have occurred in places of worship around the country in the past 3 years. It really speaks to an illness in the fabric of our society that we have to come to grips with. But today we're here to celebrate something else, and I want to thank particularly our partnership with Barry Ostrowski, who's with us today, and Jack Morris, the chairman of the RWJ-Barnabas board and RWJ-UH hospital board that has helped to make this possible. We have shared many management dinners with the four of us, and the three of us and Brian, to get us to this point, and we anticipate many more, because this is just the beginning. A thanks to Brian's team, who helped pull this together with Kathy Bramwell and Vince Gracias. And let me just say one thing before I turn the podium over, and that we formed a partnership here, but this isn't just a partnership to establish a new health system. Yes, it's a big health system. Yes, it will be one of the biggest academic health systems in the nation. Yes, it will be far and away the biggest in New Jersey, and it will impact what happens to healthcare in New Jersey. But it's not just about the partnership. It's about experimentation, it's about discovery, it's about innovation, it's about impact. This academic partnership can have impact that goes far beyond the footprint of the health system itself, far beyond those 2.5 to 3 million lives that we may have a direct role in caring for, to defining how healthcare is delivered, not just in the state, but in the nation. What's the future of healthcare look like? And that's why I think it's so important that the first academic exercise that we do in kicking this off looks at the future of healthcare systems and looks at some of the expert thinking about where healthcare systems are going, because we should be creating the future. We have a challenge to provide care today. We have a challenge to do what we do best, along with our partners, to help the citizens of the state. But if we do only that, we will have failed in this partnership. And I know Barry thinks the way I do about this, and that's the value, the leverage, the potential of the academic and the clinical enterprises coming together, sharing the resources of a place like Rutgers that has so much knowledge to offer, and creating a melting pot for thought that generates a new way to go forward. So I'm going to end there, and I'm looking forward to hear what our speaker, Dr. Blumenthal, has to say about this, and continuing the conversation in what I know will be a series of symposia like this over the coming years. Thank you very much.
Thank you, Bob. This morning, we welcome to Rutgers one of our nation's leading public intellectuals in healthcare. Dr. David Blumenthal is president of the Commonwealth Fund, a national philanthropic organization engaged in independent research on health and social policy issues. Celebrating its 100th anniversary this year, the Commonwealth Fund is dedicated to improving healthcare and making it accessible to all Americans, especially our most vulnerable populations. Notably, the fund was an early sponsor of rural public health efforts, supporting the education of minority students in medicine and eliminating health inequities for women, children, and the elderly. More recently, the fund has been very involved in the issue of the medically uninsured. A hallmark of their projects is a commitment to innovation backed by evidence and the use of data to drive the transformation of the healthcare system. Turning specifically to our speaker, Dr. Blumenthal was formerly the Sam Thier Professor of Medicine at Harvard Medical School and Chief Health Information and Innovation Officer at Partners Healthcare System at Boston. He's a true pioneer of health information technology and its meaningful use, and served as the National Coordinator for Health Information Technology with the charge to build an interoperable, private, and secure nationwide healthcare information system. This culminated in the successful implementation of one of the largest publicly funded infrastructure investments the nation has ever made over such a short period of time in healthcare or in any other field. Previously, Dr. Blumenthal was a practicing primary care physician, director of the Institute of Health Policy, and professor of medicine and health policy at Massachusetts General Hospital. He's the author of more than 250 books and scholarly publications, including most recently, Heart of Power, Health and Politics in the Oval Office. Dr. Blumenthal received his undergraduate, medical, and public policy degrees from Harvard University and completed his residency in internal medicine at Massachusetts General Hospital. Finally, I'm proud to say that he has been a friend and colleague for many years, and parenthetically, our kids are as well. So it's my distinct honor and pleasure to introduce our keynote speaker, Dr. David Blumenthal.
Thank you, Brian, for that very generous introduction. It reminds me of the story about when Eleanor Roosevelt was introduced by a Republican. And being the very modest lady that she was, she said, really, keep it short. And so her introducer said, this is Eleanor Roosevelt. The less said about her, the better. So I feel very privileged to be here as part of this inaugural event for your new alliance, your new partnership. I also feel gratified to be part of a celebration of an organization that comes together for the purposes of healing at this time in our history and in this immediate period in our history. My goal today is to share a few general lessons or ideas about trends in our healthcare system. Some of them may seem at first sight a little distant from your immediate problems, but I hope that you will see their relevance and even potentially their importance for you to grapple with. Some of them will be relevant to your daily work. Others are relevant to you as citizens of our healthcare system and of the larger society in which it rests. So these are the issues in which I'm going to talk about. The first is what's happening right now nationally in healthcare markets. I'm going to especially focus on the prevalence of a phenomenon which is new but rapidly changing in our healthcare system, and that is very pertinent to this event and to your situation, and that is the consolidation that's occurring in healthcare markets. And I say this as a 40-year citizen of one of the most prominent examples of healthcare consolidation, and that is the Partners Healthcare System in Boston, Massachusetts, where my home of many years, the Mass General Hospital, resides. The second I'm going to talk about is climate change. That may seem to you a really distant issue for a healthcare organization, but I think it's not, and I hope to show you why. The third, relevant to your new attempt to bridge clinical and academic sides of a healthcare organization, will be about the march of biomedical science and its implications for the frontline delivery of care. A story with both very uplifting and very troubling sides. And the last is about consumer empowerment through information, which I think we will all be grappling with in ways that are difficult to anticipate, but we know are going to affect our daily lives, both, by the way, as consumers of healthcare and as providers of healthcare. So let's start with markets. This is Adam Smith. He's the originator of one of the most powerful ideas in human history, the idea of the invisible hand of the healthcare market, the idea that self-interest pursued avidly will lead to larger public interest through the operation of markets. One of the unique aspects of American exceptionalism is our conviction that the functioning of free markets is the way to organize health systems. We are the only country in the world that holds that belief. Now, we are not all of one mind about this. There are some of us, some perhaps in this room, who believe that healthcare should be delivered outside of markets, that it is above all a professional enterprise, driven first and foremost by the interests of patients, not by the interests of the financial gains or goals of those who deliver it. And that is why so much of healthcare, unlike most other sectors of our economy, is provided through nonprofit organizations. And even advocates of markets tend to display a certain amount of cognitive dissonance about the role of markets. I saw this particularly in my role as National Coordinator of Health Information Technology, tasked with creating interoperability and information exchange among healthcare organizations. We expected competing healthcare organizations to exchange information because it was the right thing to do, even when those organizations were at each other's throats in every other aspect of their lives. Now, we don't expect Walmart and Amazon to behave that way, but we do ask competing healthcare organizations in free markets to do that without any compensation. Cognitive dissonance. Now, this paper, when I was a graduate student just a few years ago, was particularly important in shaping my thinking about markets in healthcare. It's written by a fellow named Ken Arrow. He's now deceased, but he won the Nobel Prize in economics. And he got interested in healthcare markets and wrote this paper about all the ways in which healthcare has features that make it almost impossible for markets to function effectively in healthcare. Some of those features that are violated by healthcare is, first of all, that free markets require the availability of perfect or near perfect information. Consumers and producers have to have that information. Well, we know that the asymmetries in information between producers and consumers of healthcare are huge, and that consumers, especially individual consumers, often lack the information they need to be good consumers, to be intelligent consumers of healthcare. Beyond that, we also know that prices are not available to purchasers who want to purchase healthcare in this market, in any market. Markets assume that consumers are rational. Those of us who deliver healthcare see many, many consumers who are not only not rational, but not conscious, or cognitively impaired, or mentally disabled in one way or another. But we cannot not serve those patients, and they cannot choose not to have our services. The classic economic theory assumes that there are many producers in any market of a given good or service. I'm going to show you through some data that that is not true in healthcare. Competition is vanishing on the provider side in healthcare markets. Nevertheless, the ideology of competition, market fundamentalism, remains an incredibly powerful force in American politics and in the governance of healthcare. And markets in almost every other segment of our society, think about the trusts that were busted at the turn of the last century. Think about the aggregation of power among a few high-tech companies. Markets tend toward consolidation in many, many other sectors of our economy. We are seeing the same thing happening in healthcare. The Commonwealth Fund has supported an economist named Richard Scheffler, who worked at the University of California, Berkeley, to study the phenomenon of consolidation, both on the insurer side and on the provider side around the United States. And this is some of what he found. 90% of provider markets are, by the standards of economists, highly or super concentrated. 60% of insurer markets are, by the standard of economists, highly or super concentrated. To put it bluntly, this is incompatible with the functioning of free markets. Now, employers would appear to be a very important potential counterweight as purchasers to this consolidation. They are actually the major provider of insurance other than the United States government to the American public. They insure 156 million Americans and their dependents. They pay 34% of the U.S.'s healthcare bills. But employers, the great majority of the millions of employers in the United States, are small to medium-sized businesses who don't know much about healthcare, and they have no local market power. They cannot, by threatening to withdraw their business, affect the way in which consolidated providers choose to make their decisions. And even the much vaunted Amazon, Berkshire Hathaway, JP Morgan Chase union is not going to change that, because their millions of employees are scattered across hundreds of markets around the United States and indeed around the world. This trend toward consolidation is very much on the mind of regulators and policymakers. And it challenges the basic principles through which we currently think about and organize our healthcare markets. It will reach a tipping point. It's already happened in my home of Boston, where Partners Health System has been increasingly constrained by public regulators in terms of what new assets it can acquire, and gets increasing pressure just short of price regulation to constrain its costs. And I do think we are going to see that increasingly, not because government doesn't believe in markets, but because markets are not working. Let's turn now to climate change. This is Puerto Rico. after Hurricane Maria. This may seem a little distant to the local scene, but this is New Jersey after Hurricane Sandy. When I woke up this morning to WNYC, I was listening to stories about New Jersey residents who are still waiting for relief, promised relief, for rebuilding from the aftermath of Hurricane Sandy. So climate change is part of your lives, part of all our lives. Now, there are three ways in which climate change affects and is affected by the healthcare system. The first of these has to do with CO2 production, greenhouse gas production. The second has to do with the changing epidemiology of disease in temperate climates. And the third has to do with challenges to the resilience, to the ability to function of healthcare systems under the pressures of climate change. Now, it may seem bizarre to talk about CO2 production to an audience like this. I mean, we're in healthcare. We're not in fossil fuels. We're not producing gas or oil. We are unaware of the global impact of the United States healthcare system. If you took the US healthcare system and put it on an island and floated it out into the North Atlantic, say somewhere near Iceland, it would have the 6th largest GDP in the world. So here you see the US, China, Japan, Germany. Actually, it's the 5th, excuse me. And there's the United States healthcare system, $3.3 trillion, bigger than France, comparable to Germany. We are a big, big entity. So it may seem a little less surprising that we are among the largest producers of carbon emissions in the world. We produce 7% of greenhouse gases. Our healthcare system produces 7% of greenhouse gases. For your children and your grandchildren, we are a problem. Not by intent, but simply by virtue of our size. We are in fact comparable, if you look at this graph, to Germany and equal to Iran in the level of production of greenhouse gases from our healthcare, just from our healthcare facilities. That's why this is an important commitment. The commitment that Kaiser Permanente has made to being carbon neutral by 2020. There are a few other places scattered around the United States that are making that commitment. But as your major new healthcare system aggregates and chooses to govern itself, this issue will come to your front door because we are collectively too big to ignore it. There's another way in which climate change will come to your front door, and that is illustrated by this tragic but all too common scene. The migration of populations from the poor south to the affluent north, and the warm south to the less warm but warming north. These migrations are influenced by climate change. The caravan that you can't avoid hearing about, by some explanations, is rooted in part in a drought that is affecting Central America and causing food insecurity in the countries from which some of these migrants are originating. And the hot areas of our planet are going to be increasingly untenable, and the less hot areas are going to be increasingly attractive to those populations. Now, aside from all the political disruption that follows these migrations. There is a healthcare consequence. These individuals bring their diseases with them and their health problems, and they show up in places like Newark, and in Boston, and in Chicago, and in Los Angeles. And their health problems become our health problems. Climate change also brings the vectors of disease that were not prevalent in our climates, but become so. The Zika phenomenon, which has faded from the news recently, could become a creeping problem heading north if climate conditions make that possible. And as the father of a woman of childbearing age, that certainly is on my mind as a father, but it would also, I think, be on the mind of people who are concerned about population health. Just examples of the ways in which climate change becomes a health problem for us as providers. And there is a third way. So this is a hospital. I don't know whether it's in New Orleans or whether it's in Houston, but the problem is clear. My Mass General Hospital, where, by the way, my children are both physicians, sits right on the tidal basin of Boston Harbor. It is a few feet elevated above sea level. In 30 or 40 years, the emergency room is going to be underwater. And the disruptive events that are increasingly, that were millennial events, are now annual events that are part of the climate change phenomenon, will come home to roost in your management of your institutions. Building resilience into your construction, the way you have to build resilience into earthquake prevention in California, is going to be part of your challenge as managers of healthcare organizations, especially if you're anywhere near the water. So let's refocus now to another topic, and that is the phenomenon of miracle cures. We have seen these in a lot of specific diseases. This just illustrates three. Harvoni, the cure of hepatitis C. On the bottom, a reference to treatment for cystic fibrosis, which now has new treatments, genetically based treatments available, Kalydeco and other agents. And then, of course, CAR-T, developed just across the border, south of here at the University of Pennsylvania. A seemingly miraculous treatment for treatment-resistant white cell or blood cell hematologic tumors. And there are more coming down the line. We should expect before too long genetically based CRISPR-induced treatments for cures for sickle cell anemia and hemophilia. As a physician who cared for patients over many years, these are jaw-dropping new events. Like all the physicians in this room, I'm sure I can remember specific patients who suffered from these ailments, all of them, who I was unable to relieve of their suffering, much less to cure. And now we have these dramatic new treatments at our disposal. The prices are also jaw-dropping. And to put a point on it, as these cures pile up, miracles for which the biomedical sciences, represented by Rutgers University and others, can be justly proud. The financial consequences of these cures at current prices are unaffordable. It will induce us to all kinds of financial maneuvers that will raise premiums very high, will cause us to amortize costs over years and years, at rates that will make student debt seem affordable. And we don't have a solution. And this will come to bear on those of you who deliver healthcare services, because you will be faced with looking at individual patients and saying to them, you can't have this. I have a cure for you, but you can't afford it. We can't afford to buy it, and you can't afford to pay for it. Now, it seems like this is a new phenomenon. Biomedically, it's new. But it's not. There are old miracles. When I was an intern resident and a primary care clinician, I cured people of pneumococcal meningitis and pneumococcal pneumonia and pneumococcal arthritis with dirt cheap penicillin G. Cured them. They would have been dead in 1935, but they were alive when I finished administering their 10-day course of treatment. Insulin cures diabetic ketoacidosis. Hydrocortisone cures Addison's disease, which President John F. Kennedy suffered from. Chemotherapy has basically cured most childhood leukemias. Vaccines miraculously prevent polio, measles, rubella, chickenpox, now HPV, and cervical cancer is dropping like a stone in prevalence where vaccination is common. So what's new about these miracle cures? What's new about our inability to afford them? What's new is the political and economic context. What's new is patent law and its application, orphan drug law, which gives drug companies who provide cures for illnesses with less than 200,000 victims in a given in the United States, 7 years of market exclusivity. That's 7 years without competition. What's new is the consolidation of generic drug manufacturers so that there are now, for some drugs that you could barely give away for pennies, now costing thousands of dollars a treatment. What's new is the failure to create effective channels for the regulatory approval of biosimilars in the United States, which the Europeans have managed to do. And what's new is the clever legal use of patent law to delay the introduction of generics by dreaming up patents that are not really innovative or novel, but delay through legal procedures the introduction of generic competition. Another thing that's new, but harder to pinpoint, is the financialization of the biotech and pharma industries. The penetration of a Wall Street mentality that places the interests of investors first and foremost and way ahead of the interests of patients and providers. This problem of escalating drug prices for specialized pharmaceuticals was created by humans and can only be solved by humans. It requires reforms in patent law, orphan drug law, FDA regulation, antitrust enforcement in the generic drug industry. Cures are not new. It's how they're treated legally that is new. You as professionals on the front line will deal with the agonizing consequences of the unaffordability of these medications. You will deal with them as you stare in the eyes of patients who are facing financial ruin in return for the opportunity to live a longer life. And you will have to be part of the political discussion that shapes the resolution of the conflicts that arise from these challenges. Now, the last trend I want to talk about is consumer empowerment. We hear a lot about consumer empowerment. I certainly, when I was still practicing, saw a lot of patients come in with those legendary printouts from the internet. Patients are more skeptical. They're asking more questions. They are getting lots of additional information that they didn't have available before. But I don't think we've seen anything yet. When this guy walks into your office, you will know that something has changed. We are on the cusp of a revolution in information availability and use that is truly different from anything we have seen up to this point. It's the result of a series of technical, legal, and regulatory changes, which, unlike the ones I referred to in the drug industry, are much more positive and promotional of market forces in the most positive sense. So what are some of these new forces? Well, actually they start on the top with HIPAA, the much maligned HIPAA. Well, it turns out that HIPAA has other sides aside from their alleged bureaucratic constraints on health professionals in terms of information sharing. It requires that upon request, the healthcare provider offer anything that in the way of information that a patient requests within 90 days. That's the law. Patient asks for it, you have to provide it within 90 days. There have been very few penalties for not doing so, and this legal requirement has been honored in the breach for the most part. But that's changing because the 21st Century Cures Act, which is the next point on this circle, greatly increased the penalties for failing to live up to that expectation, and also required that information, if requested, be made available in machine-readable form. That is, downloadable onto a computer at the patient's request. Turning around to the other side of this circle, you'll see standard APIs. Those are application programming interfaces, but they are essentially entryways into electronic record warehouses. Those are now standardized, widely available, and as part of meaningful use and certification have to be available in every electronic health record. What that means is it has become easy to get access to patients' electronic health information. And there are also organizations, some of which we funded at the Commonwealth Fund, that have developed consumer-friendly forms and even electronic methods for requesting that information. So never to be left behind, Apple has seen this as an opportunity, and some of you, I don't know Rutgers or RWJ Barnaby's status in this regard, but there are a bunch of health systems in the United States that have now teamed up with Apple, and at patients' requests are now downloading electronic health records into Apple Health Kit. Available on your iPhone, your drugs, your tests, anything in your electronic health record, if you want it. Now, and by the way, Amazon and Google are sniffing around in this area as well. So what you have is the liberation of data potentially on a level that's never been accessible before electronically. I don't want, personally, my electronic health record on my Apple iPhone. I wouldn't know what to do with it. Most patients feel the same way. But that's not a problem, because there are lots of companies like Apple that would love to process that information and steward it for you if you want them to. And the key here is not having the information, but using it and developing applications that are useful and usable for consumers. We are on the verge, I believe, of a whole new industry that is going to take that data for patients who want it, process it, use new software applications and new interfaces to make it easy to use the way so many of your applications on your iPhone and iPad are easy to use. So what are some of the, and in fact, if you go far enough, you might even imagine an IT-enabled consumer capability like a digital health advisor. Brought to you by Apple or Google or Amazon or Watson or IBM or some new startup that has produced some nifty new variety of software. And it will have the capability to answer routine health questions, manage appointments, deliver personalized coaching, help you choose your provider with Medicare Compare and other data right at hand. If it's linked to pricing data, help you find the cheapest provider. And help you avoid out-of-network providers and figure out what you're likely to be charged if you pick an out-of-network provider. Now, lest you think this is all imagination, this is something called GP at hand, for general practitioner at hand. It's the result of a partnership between a private company and the British National Health Service. And GPs who sign up for it can enable their patients to have access to their electronic health record on their iPhone, as well as to answer some very basic questions. It's still very primitive, but it's an example of a public-private partnership, which I think offers a vision of the future that we are going to encounter, and you as providers and deliverers are going to encounter. So the question is, what are you going to do with this? How are you going to react to it? Are you going to stamp your feet and protest that it's not the right of the patient to have all this information, that it's not right for Apple or Amazon to be playing this role of healthcare advisor? Or are you going to ally in some way with this new reality? I think there are ways in which you can do that as a healthcare provider, but it's going to require new aptitudes, new attitudes, new flexibility, and innovation in the way your providers think and the way you operate. There are problems, serious problems with this new reality. There are threats to privacy. There are threats of consumer victimization and fraud. There are threats of fraudulent applications and unsafe applications. There will be regulatory hang-ups and regulatory conflict about this for decades to come. But it is possible, and in this world of information technology, the possible tends to become the reality. So I'm going to stop there. I could talk about demography, but it sounds like you're going to get a dose of that later on. I could talk about value-based payment, but I suspect that's on your lips virtually every day as you think about your local markets. The healthcare system is constantly confronting new challenges. It is what makes our work so interesting and maybe not life-prolonging. But at 20% of GDP, healthcare simply has to deal with these and will continue to have to deal with these and other pressures that we probably can't imagine yet at this time. So you are in the right business if you like living in interesting times. Thanks very much for your attention. Sure. Happy to take a question or two, if time permits. Yes, Dr. Barkin.
Yeah, you mentioned in the beginning the issue of consolidation and the fact that market forces don't work.
You're being offered a microphone.
A microphone. I usually don't need a microphone, but you were talking about consolidation and the failure of market forces in the United States. You did allude to the fact that CMS and Medicaid and some of the other governmental providers are perhaps now our major payers. You and I remember a day when Medicare was, oh my goodness, we have a Medicare patient in the house. And the fact that for many of us it is now our best payer is a turnaround. But you've steered clear of the question of whether we should be moving towards a single payer system or whether we are locked into the kind of system we're in now. So I'm going to ask you that question. What do you think?
Well, when I was a medical student, I testified before the House Ways and Means Committee in favor of a single-payer system. That was just a few weeks ago. I worked for Senator Kennedy on Capitol Hill, and I worked for President Obama during his campaign and then as part of his administration. So I have an imprint and I have a branding. And the Commonwealth Fund is, its logo is affordable quality health care for all. I think we can and should get to universal health care insurance. Single payer is not a requirement for that. The Netherlands is a great example of a system that uses private insurance to get to universal coverage. And I have trouble imagining that the United States Congress will ever put the insurance industry out of business in the United States. So what I believe in philosophically and what I believe in practically are two different things. Single payer is one route to universal coverage. It's not the only route. When I worked for Senator Kennedy, he expressed regret that he had been inflexible personally on this issue of single payer and whether the government should be the insurer or whether there were other ways of getting there. Because he had thought that when Richard Nixon was president, they might have come to an agreement on this issue if he had been more flexible. So that's been how I've thought about the issue for much of my career. We can get there, but we won't get there, I don't believe, not because it's not ideal, but because it's not politically possible through the device of a single payer like, for example, Medicare for All.
Hi, Jonathan Potter, Dean of School of Communication and Information. One of the things you didn't mention in your talk, and I'm sure it's not because you're not interested in it, is prevention and the way in which these kinds of issues, very significant issues that you've highlighted, play out with how you can make it cheaper by stopping people coming into the system, and the way these kind of new technologies might support community-based initiatives, family-based care initiatives, ways of which are inducing advice compliance and so on in terms of obesity, smoking cessation and so on. I'm wondering how you see this all joining up together.
Well, of course, prevention is a preferred approach to illness, and it is greatly to be wished for, and we greatly underinvest in it. It's not surprising that we do, given what behavioral economics teaches us about how people make decisions and the way they value short-term rewards as opposed to long-term rewards. We take that to an extreme in the United States. Since I was a graduate student, it's been a mantra in the public health community that we underinvest in public health, and we certainly do. There is also the huge question of social and economic influences on health, which probably exceed in power the influences of health, of the resources we put directly to illness prevention. So we have a huge agenda in the United States, and the question is how to get there in our political environment. You can see I'm a political pragmatist. I don't believe in tilting at windmills. Not that it isn't important to have someone doing that, but I tend to focus on the practical. I think that in the short term, the fastest way we're going to get to investments in public health that are cost effective and whose value is carefully measured against return and against treatment will be through organizations that are bearing financial risk, taking responsibility for the health of their populations, and investing in some of the high ROI social and economic and prevention-related treatments and services that we need in the United States. That is a very poor substitute for public spending on those, but it is the only one I see happening right away. We have an $800 billion deficit annually right now. We all know why, but we have it, and it is a huge constraint on public spending. Now, particular states can do better, and I think states should be one focus of activity for people concerned about prevention.
Dr. Blumenthal, thank you very much. Bob Light from Department of Family Medicine, Community Health at Robert Wood Johnson Medical School, Rutgers. I was very pleased you brought up the issue of climate change and wanted to call your attention that the National Medical Association at a conference last year passed in Florida a resolution on climate and health equity, making the point that our health disparities not only are caused by disparities in care and access, but disparities in terms of how different populations experience climate. And in particular, there was a lot of discussion about the concept of what's called ecosyndemics, which is the interaction of different epidemics and the interaction of different climatic forces that can cause heat sinks in urban areas where people may live or in rural areas and stuff like that. So I'm wondering, do you see foundations and other funders getting involved with dealing specifically, even at the level of population health, with climate change and health equity issues?
I think that's quite possible. There are a lot of foundations that are heavily invested in dealing with global warming, not necessarily specifically with healthcare. The Rockefeller Brothers Fund, for example, has that as a major priority. I think the Gordon and Betty Moore Foundation does as well. And the Robert Johnson Foundation nearby here is very much about social determinants of health of all varieties. So I would think they might be a source of that investment. Though I am personally interested in this topic, it is not a focus of the Commonwealth Fund, which tends to much more focus on access and coverage and delivery system reform, where there's plenty of work to do also.
Thank you, David. We'll have a little bit more time later. If I can ask the panel to come up. So, David, thank you for that thought-provoking talk. David, you're part of the panel. Sorry? The break was just to get people up here. We'll transition now, if I can have the panel come up here. We'll transition now to a reflection of what David outlines as global challenges facing the healthcare system and what this will mean locally for us in New Jersey, at Rutgers and at RWJ Barnabas. Let me take a moment, though, to introduce our panelists, and thank you all. The congressman is not here yet. He's on his way. Okay, so we'll wait in introducing the Congressman Pallone until he gets here. Also, unfortunately, Sharif Al-Nahal, who's the Commissioner of Health, gave us advance notice. He wasn't going to be able to make it because he needs to be in Trenton for a meeting at 12. Let me introduce everybody to Barry Ostrowski. As you know, Barry is President and CEO of RWJ Barnabas Health, New Jersey's largest and one of the nation's largest health systems, comprising 11 acute care hospitals. Barry's the one holding the I was going to say holding the microphone, but he's not the only one holding the microphone. On the end is Shireen Gabriel, Dean of Robert Wood Johnson Medical School here in New Brunswick. Robert Johnson, Bob is Dean of the New Jersey Medical School in Newark. Let me, and I'm going to sit down in 30 seconds, but Barry, as the CEO of New Jersey's largest academic health system, what do you see as our role in population health management?
Hello?
Test.
Thanks, Brian. Thank you, David, for that great presentation, although before I got onto this mess, I was a lawyer, and I contemplated going back to that profession while you were telling us what our challenges are. It's a little scary. And thank you all for attending this. We are proud to be, of course, Rutgers' partner in this grand new approach to delivering health care and improving the health of our communities. And of course, events like this are critical, I think, to sharing meaningful ideas and how we can do that. Much of what was said earlier has been a dynamic in our producing what we hope is an effective strategy, and frankly, objects of that strategy, for the most part, tend to be the health of the community. For 100+ years, organizations like ours, frankly, were in the business of vending healthcare services. Obviously, we all know volume was the driver of financial success, not necessarily better health. And over these years, we've learned, of course, that the health of our communities are really the result of dynamics beyond that which the conventional healthcare system typically addressed. So for us, we think that in order to be successful, we should be adjudicated against the appropriate metrics when evaluating the health of the people who live in our communities. And we think that means a series of initiatives that has to be important in our commitment. This partnership with one of the great universities on the planet is first and foremost among those strategic moves. We think the intellectual capacity of Rutgers, both in healthcare and social service, is critical. We want to be able to train the best future clinicians. We want those clinicians to understand their role in helping the health of our communities. We want to invest in research so that some of those miracle cures will in fact become more available and ever more available to the communities we serve. And we want to sit down with our partners at Rutgers and talk about the social determinants that we know affect the communities that we serve. And so for us, this great partnership is about how we, good morning, Congressman, how we are able to best mobilize our assets in a way to have direct and important impact on our fellow citizens of New Jersey. I happen to think that whether you are moved to improve the health of our communities because of a soulful commitment to make society better, or whether you think that improving the health of our communities will reduce the strain that individuals place on a healthcare system that frankly is more or less going to be insolvent in not too many years, you have to be motivated to affect the health of the individual. And certainly some of the macro dynamics that we learned about this morning impact how we can mobilize the assets that we have in order to improve those communities. In our view as a healthcare system, this is an obligation. This is not simply a business plan. And I think the fact that we don't have to report necessarily earnings per share, that we can pursue a mission, that the mission of our organization and that of Rutgers is perfectly aligned. It has been improving this state for many years, and together we can improve the health of our communities. So for us, it's a culture. For us, it's a mission change away from just selling healthcare services to investing in our communities. And I think in the future, the most successful healthcare systems in our country will be ones that will distinguish themselves in applying their resources to address the social determinants of bad health and to, in fact, invest at the very same time in the conventional clinical care that's necessary, the medical research that's required, and improving the access of all of our fellow citizens to the advantages of that kind of strategy.
Thank you, Barry. Let me introduce everybody as well to Congressman Frank Pallone. Thank you. Who represents the 6th District of New Jersey, which covers most of Middlesex County and parts of Monmouth County. He serves as ranking member of the House Energy and Commerce Committee. His legislative focus is on protecting our environment and making health care affordable and accessible for the American people. Today also happens to be Congressman Pallone's birthday. So we wish you a happy birthday and thank you for spending your birthday with us. So, let me turn then to a question for Congressman Pallone. As the ranking member of the Energy and Environment Committee, what role do you see for the federal government in addressing the nexus between climate change and the healthcare system?
Well, I mean, the biggest problem that we have, and I'm obviously going to be very political and partisan here, is that we have a president and a Republican leadership in Congress that doesn't agree that climate change is human-induced, right? So, for example, on the Energy and Commerce Committee, where I'm the ranking member, which means I'm the lead Democrat, at the beginning of every organization for the committee, we put together an organizational chart, and I always say that that should include climate change, and they take it out. And so theoretically, so that means we don't even have hearings. We don't have a markup. We don't address the issue at all unless somehow you can get around it by saying, well, it's not human-induced. So therefore, you can talk about resiliency, building flood control devices, and and obviously I'm a big supporter of that, to prevent a future storm, but you can't address greenhouse gases because it's not human-induced. So I mean, we have a basic political problem here, that there's not the recognition that climate change is a function of anything that human beings have done. And if you take that position, I don't know where you go. You really go nowhere for all practical purposes. But I mean, I think that the question is important because how do we get beyond that? In other words, how do we convince those on the right, I'll say instead of Republican, those on the right who want to deny climate change to say you shouldn't deny it, or get to the point where they accept it. And I do think that when you talk about safety and health, that's the key. There are many people out there who don't want to do anything about environment or don't want to regulate anything. But if you say to them, well, if you don't, you're going to have a problem in terms of human health or safety, then they recognize that the public is going to require that they take action because they don't want to breathe dirty air, they don't want to drink unclean water, they don't want to have some occupational hazard that comes from toxic materials. So that's important. I mean, I guess I'm just going much more further back to the more basic thing, is how do you get leaders who don't want to accept these things to say you better accept it because it's going to impact health and human safety. I mean, I've never quite understood how anybody can be against environmental regulation or trying to clean the air or clean the water, because theoretically it's one ecosystem and we all breathe the same air and drink the water. And so there's a direct relationship, right? I mean, the most obvious answer to your question is that, because it's one world, that climate change is going to warm the planet. You're going to have more diseases. You're going to have more viral infections. You're going to have more mosquitoes. These things that are going to directly impact human health. And so there's clearly a relationship between the two. What we do now, for those of us, on the side of, feeling that this must be addressed, is we try to get around it by saying, okay, you don't believe that climate change is human-induced, but it's still out there, and so you must take certain actions. And so, when it talk about storms, it means, building flood control devices. You talk about disease-borne illness. Well, we have to do more research, and we have to have vaccinations, and we have to do other preparatory things without referencing exactly how this happened, that it was caused by human activity. So we're certainly moving in that direction. I mean, there's certainly, this year, regardless, you may have, you hear the media accounts of where the president says he wants to cut back on federal spending, he wants to cut NIH, he wants to cut research. Most of that doesn't happen. Actually, if you look at the federal budget this year, there's actually an increase in funding for research. There's an increase at NIH. There's the Environmental Protection Agency, instead of being slashed in a third by what the president suggested, was actually just decreased by 1%. So, we are actually, I think, moving towards trying to address the health and safety impacts of climate change. But it's just a lot more difficult in an atmosphere where you have the president and the Republican leadership still being climate change deniers. So, you know, I don't want everyone to panic and say we're not addressing this. We are, but we need to do a lot more. And the only way to do that is to say, look, you shouldn't be denying these things because it's pretty obvious from the impacts on our health and our safety that they are real. But, you know, we're not there yet. It's tough.
Thank you. David, following up on one of your comments, you expressed the understandable economic concerns about consolidation in the healthcare industry. How do you reconcile that with the investments needed for IT, your other part of your life, and with the scale needed for population health? Again, something obviously you're very expert in.
The issue is, I raised the issue of consolidation in the context of seeing this as a market-based healthcare system. I have some personal concerns about treating healthcare as a marketable item. And so I do believe that markets allowed to function without regulation tend toward consolidation, and that the consolidation results in a failure to control prices and to improve efficiency. We may choose, for reasons you've just suggested, to accept that consolidation and acknowledge the failure of markets and the principle of markets in healthcare for the reasons I highlighted in my talk, and say, yeah, you do need a certain amount of size, you need a certain amount to invest in the critical capital items like IT that are necessary. I don't think you needed to invest in population health. What you need for that is evidence of value from population health investments. But that you may want to have an alternative regime to the market as a way of making sure that what results is socially optimal. I just think we need a conversation about that. We need a conversation about the role of markets in governing our health system. As I said before, there is no place on earth that uses markets the way we do to control healthcare. And as a matter of fact, if you really want to see what happens when you let markets function unrestricted, go to, of all places, China, which for about 20 years from about 1984 to maybe the middle of the last decade, had a completely basically unregulated healthcare system that resulted in incredible personal discontent, dissatisfaction, physical attacks and murders of physicians because of popular anger, to the extent that the government had to step in and basically say, markets are not working. We have to insure people against the cost of illness, and we have to start licensing physicians, which they weren't doing before, because that's not required in markets. You don't license people who sell, air conditioners and toothpaste. So I think that there are a whole lot of things that we need to discuss about the role of markets in healthcare.
This one's working. Yeah, it's working. Dean Johnson, Rutgers is a center of innovation and discovery in healthcare. In this age of advancing medical technology and increasingly personalized medicine, and David gave us some examples of that, how do we determine which care should be accessible to all and what care should be left to personal preferences and financial needs? To ask you an easy question.
Very, very easy question. The answer is that everyone should be able to get all care possible, and we should pay for it. But that's not what we do. One of the things that I've been advantaged to is to be involved in healthcare at a point where I actually witnessed a miracle. In the 80s, when I was working in a free clinic in New York City, I saw many of my patients just drop dead. We had no idea what was going wrong with it. And I became involved in trying to discover what that was. And through what I truly see as a miracle, we discovered the virus that caused this illness. Not only that, we discovered a way to test for that virus. Not only that, we discovered effective treatments for that virus. And then we developed health systems to take care of that virus. And of course, this is the miracle of HIV. And we've gone in a very short period of time from an illness that was universally fatal, at least in the United States, to a point where it is now a chronic illness. So that's really remarkable. As some of you know, in addition to running the medical school, I also have a fairly large clinic for adolescents who are HIV infected. And today, if they come into our clinic this morning, we can do all the tests, and then tomorrow they can start medication, and they will never, ever get AIDS. They'll be able to live their lives in a way that they could have just before they came in to see us. That's really remarkable and a miracle. However, that miracle costs $36,000 a year. $36,000 a year for the life of every one of the young people who comes in. So can we actually pay for that? And the answer that the nation has responded to is, yes, we will pay for that. We'll pay for it for everybody. So insurance companies pay for it. If you don't have insurance, then there's the Ryan White Care Act. That will provide the resources. And at the state level, there are mechanisms to provide the medications. And so one of the things we can do if we decide at a national level that this is important enough, and if we want to do it, we can do it. However, in order to do that, it takes a lot of political influence. And the miracle of HIV was because of the political action of many people who were infected, who were organizing on a community level, and still today begin to continue to make sure that the resources that are needed to continue this level of care are continued. Now, it's different in every state. And we happen in the Northeast to be at a place where the states have made sure that that care is provided. Other places in the United States, it's not as easily done. And of course, throughout the world, we don't have the same availability of this care. So, Brian, we can do it. There are great benefits to all of us to do that. Yet there will be costs, and the $3.3 trillion that we spend in healthcare will continue. But I think it's well worth it to maintain it. One of the other things that is another important part of HIV care, and that is that we clearly understand with HIV care that it's not enough to have the doctor and the nurse and the pill. You have to also consider the social issues associated with the disease. And so if you have HIV and you have no place to live, it's very difficult to do the things you need to do to make sure that you are able to take advantage of treatment. If you have mental health issues, it's difficult to do that. And so the CARE Act provides all that and provides resources for housing, resources for jobs, and resources for mental health. And that whole system has been very effective, and it worked for HIV. It can work for other illnesses as well.
Thank you. Dean Gabriel, what's the optimal role of our patients in our evolving healthcare system?
So first of all, thank you, Brian, for putting this together, and thank you, David, for some very thought-provoking comments. So I'll start off by saying that I think engaging patients, and I would add families, in helping us solve the problems of healthcare is a largely overlooked but potentially huge opportunity. And then I'll maybe share my bias here, which is why Brian probably tossed this question to me. So I'm somebody, as many of you know, who spent, nearly 30 years of my career at an institution that works very hard every single day to put the patient at the center of every decision, and that's Mayo. Whether it's making a decision where to place a parking lot or making a decision about a laboratory. And I think that discipline is important for every institution. I also had the privilege of being chosen by the USGAO to be one of the first cohort of individuals in the Patient-Centered Outcomes Research Institute, which is a part of the Affordable Care Act. And in that effort, the goal was to have patients and families guide us, not just in thinking about clinical care, but in thinking about what research is needed for the country to improve our clinical care. And then, of course, here in my medical school, Robert Wood Johnson Medical School, one of the first things we worked on, and this is something that was part and parcel of who this institution have always been, but we just made it more visible and more public, that our central philosophy was putting patients first. And so patients first is, you know, all over every door. So thank you for that. I do believe that this represents a unique opportunity, engaging patients, engaging families, in helping us drive strategy across all missions as healthcare evolves. So not just understanding what patients needs to think about how we advance our clinical strategies, but involving patients, involving families as we build our research plans, involving patients and families as we figure out how to better educate the health professionals of the future, and engaging patients and families as to how we develop community programs that can better engage and better address the health of the communities we serve. Now, I see two big obstacles to that, which is why it hasn't happened as quickly as maybe we would have all liked, and maybe I'll end, once I discuss those, I'll end with a question to other folks to see if they agree and to comment on it. One is the longstanding paternalism of medicine and of healthcare, that, you know, we know better, that has been disproven over and over again, but it still exists, and that's something that we continue to work on in our profession. And I would say the second one is one that David and some of us spent some time talking about already today, which is the economic incentives that drive medicine and that drive healthcare. Those economic incentives are often run counter to what patients want and what families want and need. I mean, one example is chronic disease versus acute disease. Figuring out better ways to care for our elderly is not a money-making venture, but it's very, very much necessary. Some, you know, acute care surgical procedures do more for the bottom line. So I think those economic incentives are really important when we think about how to optimally engage our patients, how to optimally engage families. So I just maybe ask folks if they agree with those notions.
Could I comment? With regard to the first one, paternalism, and I'm not thinking of it in terms of paternal versus maternal, because I don't know if you meant it that way.
No.
Is
we know better.
Yeah. I remember when I started out 30 years ago, and I'm just being totally, you know, talking about the politics of it right now, which is maybe not what you meant, but it piqued my interest, is that I remember when I was first elected, I represented Ocean County at the time. Now I don't know. I have Middlesex and Monmouth, then I had Monmouth and Ocean. And I went to the Ocean County Medical Society, and I heard all the doctors there, pretty much all of them say, well, you know, we know what's best about medical care, and, you know, we don't really want to get involved in politics. You know, we don't want to write letters. We don't want to petition our politicians because, you know, that's sort of beyond us. They really were saying that. And I said, well, that's very nice. I said, but the way medicine is you know, progressing here, in 20 or 30 years, you'll have no say whatsoever in anything that goes on unless you get involved in this politically and start saying, you know, that understanding how the federal government, the state government is, you know, either going to put you out of business or make you irrelevant. And there has been a change, I think, in that certainly more and more physicians, physician groups, hospitals, you know, lobby and get involved in politics and legislation, certainly much more so than was true 30 years ago. But it's still true that there's this notion out there that, you know, if I'm a doctor or I'm a PhD or whatever I am, that's too dirty for me to get involved in. And it's extremely detrimental to healthcare, in my opinion, when the people that are the experts, whether they be physician or hospital administrator or whatever, don't get involved, because then the things that they care about fall by the wayside, and it's not good for the system. Your second thing I forgot, but I do want to comment on that. What was the second thing you mentioned?
The second point was the economic incentives that drive healthcare are an obstacle
Right.
to meaningfully engaging patients and families to help us make things better.
And you were also talking about in terms of the seniors in particular.
Yes, yeah.
Well, I
so
don't know,
makes-
again, if this is what you were talking about, but one of the, or what you were asking to comment on, but one of the big concerns that I have is that even when we move forward with the Affordable Care Act or Obamacare, which I was involved in drafting at the time, we have very much, we're still not doing enough for prevention, and we're certainly not doing enough in terms of community-based long-term care. And part of the problem, and yet those things will save money, right? In other words, we know that if we do more preventative care, it's going to save us money, right? So then theoretically, there's an economic incentive to do more in terms of prevention, to try, rather than put people in nursing homes or institutionalize them in hospitals, to have them have, personal care at home or community-based care, so they don't have to be institutionalized. Maybe you don't like the term institutionalized. Yet even though there's that economic incentive in theory, right, because it's cheaper, it doesn't happen. And we just have to, I think that, again, I'm being political or maybe PR oriented here, because that's, where I come from as a politician. We need to stress more that, that there's a huge savings, if you will, in prevention, in community-based care, rather than institutional care, and that we need to more and more push in that direction. I know that's happening to some extent, but it's not happening enough. And so one of the reasons that the Affordable Care Act or Obamacare did not have any kind of long-term care component that would try to emphasize community-based care was because of the way that we formulate legislation and score legislation, so that those savings were not really, did not materialize. And we couldn't show that, through our budgeting and the way we score things, that there would be tremendous savings in that respect. So I do want the way medicine is moving and the way healthcare is moving, but there cannot be enough emphasis by all of you in saying, look, do more for prevention. Do more to try to keep people in the community or at home. And I don't know if that's what you were getting at, but I did want to mention it.
Bob, you want to come in?
Yeah, there's another aspect of this that I hope we are able to discuss before we end today, and it's really pertinent to us, to Rutgers, and that is the workforce. One of the things that we do uniquely is that we produce every aspect of the healthcare workforce that's needed. And one of the reasons why healthcare is so expensive is because of the inflexibility of the healthcare workforce. If you had a truly free market, the workforce would change depending on demand. Well, we don't have that in healthcare. For example, in big hospitals, especially urban hospitals, you have a workforce that is there in many cases to provide workforce or the economy of the community. And this is true certainly where I come from. And the change in demand for services is countered by many things. For example, we wanted to close pediatrics at University Hospital. We couldn't do it because of a political issue. We were responding to the demand issue in the workforce and in the public, but couldn't do it. And therefore, the cost goes up. The other issue is that we spend so much time training individuals who are components of the workforce, especially on the physician side, that if demand changes, it's very difficult for the workforce to go back and forth. So I don't know how we do that, and I don't know how we correctly design what the health workforce needs to look like. For example, how many MDs need to be there and how many nurse practitioners, or how many physician assistants, or how many of other types of individuals. And we don't do that very well. Because we don't do that very well, we have a cost that continues beyond the point where there's real demand. And we have to figure that out. And maybe at one point during the Clinton administration, there was an idea that floated around that maybe we should decide how many of each of the types of individuals would be trained, and people should be assigned to those positions. I don't know if that's where we need to go, but we have to grapple with that before we go on.
You know, so at the risk of being a contrarian to a certain extent, this all needs leadership, it seems to me. I take what the congressman has said. He and I have known each other for a long time, and I believe, frankly, very much in the same way he does. So who's going to step forward and lead us on this? In my view, and I could get fired by my board for this tomorrow, but the truth of the matter is, running a big business called a healthcare system that's not for profit, I think we should step forward. And I'll tell you why. We can't wait for policies to come out of government because of the political bureaucracy and, frankly, particularly now, the political issues. I don't think there's going to be an effective change in reimbursement that some of us have been dreaming about for years. And so I look at an organization like ours, which has been successful thanks to some of the counterintuitive incentives that have been in the healthcare system. We've been able to accumulate a certain level of resource of which I am proud, and our system should be proud. And so we're saying, look, we think we know how to determine what the right delivery pod of professionals may be. It is a blend of physicians and PAs and nurse practitioners, and regardless of who's manufacturing those people, this is the model we want to populate. And yes, perhaps we can, through our partnership, better define how they're manufactured or the quantity in which they're manufactured. I don't mean to commoditize people, but just from the standpoint of thinking about it. So we're going to step forward and say, these are the effective pods for the delivery of care. When it comes to public communication, I think this is one of the great shortfalls of our industry historically. Not only don't we speak to the patients the right way, we have no idea how to speak to our community. At least the patient is in a relationship with the deliverer of health care, and by extension, his or her family. But if we're really going to get to community health, we have to talk to people before they become patients. And the one thing the healthcare delivery system has studiously stayed away from is doing that in any productive way. Now, I'm old enough to remember when we had a public campaign about litter. You know, don't be a litter bug. The truth of the matter is it hasn't been greatly successful, but at least we faced the issue. We need to develop, and we are trying to, with, of course, our colleagues at Rutgers, a public information campaign to try to engage the public before their patients in understanding what it takes to lead a healthier and happier life. I think that's what's crucial if we're ever going to get at having happier and healthier communities. Now, that having been said, that is not necessarily consistent with the best business plan for an organization. I can't prove to anybody in my organization that investing in the social determinants programs, talking about this kind of communication, spending time trying to develop a counterintuitive financial model of delivery of care is going to show up effectively on our P&L next fiscal quarter. It's not. But the reason we are not for profit, and the reason we are mission driven, and the reason we are who we are is to address that. When the formal policies actually appear, and when the reimbursement changes, we should be in great shape to be able to do it on a grander scale. But from my view, if we ignore those needs right now, we are actually underperforming our mission, and we're certainly not helping as many people as we could help. And so we're going to try to step forward with our partners at Rutgers and actually address some of these issues, admittedly in smaller communities versus the macro approach, but I expect that there'll be positive results from that.
I think that's a terrific statement of purpose, and one that's especially hard to take on in the fee-for-service environment. If you are engaged, if you are in a risk-bearing organization, which increasing numbers of organizations are, there may in fact be an actual ROI to investing in social determinants, so-called. We actually at the Commonwealth Fund, along with 5 other foundations, have put up a website called the Better Care Playbook for Complex Illness. And in that playbook, you will find an ROI calculator that looks at things like investing in food, investing in transportation, investing in housing, and tries to provide for you some idea of what expected return on investment you can get. That is, though, assuming that you are paid on a prepaid basis, not on a fee-for-service basis. If you are paid on a fee-for-service basis, there is no way that it makes business sense to prevent illness.
And just so everyone knows, in New Jersey, there is no at-risk contracting in the healthcare system. So precisely David's point, until that should happen, and we may in fact ultimately demand that it happen so we can afford to have the programs that we've described. But right now that is not the case, and so this will be an investment in the future, but not one that'll have a short-term ROI.
Yep. So rather than my going through more questions, feel free to ask Steve. Go ahead. But do grab a microphone, because again, keep in mind this is being webcast and being retained.
So Steve Labuti, Cancer Institute in New Jersey. So my question kind of dovetails a bit off of what Dean Gabriel had mentioned about paternalism. And I agree with her completely that patient-centered care, family-centered care is the solution, and it's what we have to be focused on. But that almost assumes that those patients and those families are getting the proper information in which to give a decision or to put them at the center of decision making. And Mr. Ostrowski mentioned one of the things that we need to be better at is communicating. And so I would imagine if, as a cancer center director, I announced that I had a very simple solution to cancer, where if I gave it to everyone, you wouldn't get a cancer, that we'd have people lining up outside of the Cancer Institute to get what I was offering. And the reality is that in a very small area, we do have that solution. So HPV vaccination, we know, will effectively prevent HPV-related cancers. In fact, if you look at Australia, Australia's incidence of cervical cancer and other HPV-related cancers has dropped almost to undetectable levels because of a uniform policy of everyone in the right risk group getting HPV vaccination. Yet, within our own state of New Jersey, we only have 60% compliance with HPV vaccination for the current group that is eligible, and we just had FDA approval now for HPV vaccine, extending it up to age 45. So, and it's not because of lack of access, it's because of information. You know, patients, for a variety of reasons, are afraid of getting vaccinated because of misinformation, and there's also other social mores around this particular vaccine. So how do we, as an organization, grab the mantle of something very straightforward, like an available vaccine that can prevent disease, where we know it costs us not only in lives, but in dollars if folks develop those cancers? How can we just take that very small example and actually leverage it by better and more effective communication?
Well, I don't know exactly what the answer is here, but you're absolutely right in that this knowledge imbalance is the reason why, as David mentioned earlier, you know, why the invisible hand isn't working and can't work in healthcare. But ways of meaningfully engaging patients, that's why I used that sort of descriptor before engaging patients and families. The only way that places where I've seen it work is in multiple small places where you can bring patients in, provide that education, and really work with them as partners in helping make the decisions. So I'll just use PCORI as an example. So Patient-Centered Outcomes Research Institute, right? Most researchers wouldn't think that really engaging patients in helping define a research question, engaging patients in helping design the right approach to answering it, in helping understand how the results are presented and communicating those results, most of us, and I'll include myself, had not really thought that would make sense. But that's exactly what PCORI did and is doing, and they actually have patients on review groups, reviewing whether, your grants get funded or not, which again is something that we wouldn't have thought of prior to this. But the key to that, and to any of these examples, is knowledge. So bringing a group of interested, willing patients, and there are many of them out there, and really engaging them as partners, imparting the knowledge that you need to impart, and then working with them to identify solutions, whether it's HPV or research, or trying to understand, in our case, in our medical school, how to better address some of the problems we're facing in pediatrics. We have, a patient and family advisory group. So I don't think it's in one big swath. I think it's in multiple small places, kind of grassroots, where we can engage sort of side to side and across the table with patients and families and ensure that we're all working from the same knowledge base.
I don't know if anybody else in the panel wanted to.
Steve, I just one comment, and that is how do you motivate people to do things? And one of the things we do in medicine is we hang crepe. We say, if you don't do this, you're going to get sick and die. So if you get this HPV vaccine, if you don't do it, you're going to get sick and die. And people don't operate based on that. We operate based on great things happening, like winning a $1.6 billion in a lottery. People line up to buy that ticket, even though it's one chance in 300 billion, but they'll do it. So I think that one of the things we have to do when it comes to vaccines is we have to have a message that is more enjoyable. Either we make it something everyone does and becomes the standard of care in young children, and that's what we actually do, or we begin to have some other types of message. You mentioned HPV vaccine. The other big thing is the flu vaccine. It's the leading cause of death this year, and people still won't get it. And so the answer is we have to have better means of communication. Just because people know that something bad will be prevented doesn't cause someone to go toward that thing.
I mean, I don't know if what I'm going to say is directly on point to your question, but, as a politician, I get all these ideological problems, right? In other words, you're saying you want to get people involved, right? But, you got to be careful about that, too, because I'm all for getting people involved, but we get all kinds of requests all the time, from what I call ideological groups who, don't like vaccines because they think that, they're the cause of their problem or disease rather than the answer, or, don't like certain clinical trials because of their ideology. And it's really important to kind of make sure that doesn't get involved, because I have, constituents that will ask me to define protocols. And I was like, I'm not a physician, and the last thing that Congress should be doing is devising protocols, for what kind of procedures you should use as a physician. But we get that all the time. And so, I don't think that's maybe what you were referencing, but, that's a problem too. You have to make sure that people are looking at everything practically and that they understand that we've tried this and it works, and, separate it out from your ideology or theology, because otherwise, that's going to mix up and defy everything you want to do.
Actually, Congressman, I think you're spot on in terms of what I was getting at, and that is that paternalism, if taken to its extreme, can be negative. But patients often are looking for the best advice and better information. And so paternalism, in that if you believe you have the best information to give, and this is what should be done because it's in your best interest from a health perspective, is not necessarily a negative. And so we know that vaccines do not cause autism. We know that vaccines are positives, not negatives, yet we're up against a lot of misinformation. And so I think we have to try to strike a balance, especially around communication. That is, we want the patients to be involved in the decisions, but we want to try to help them to not make bad decisions based on misinformation. And certainly, you know, places like Australia that have mandated that kind of vaccination, which is very paternalistic, because a patient doesn't have the choice not to be vaccinated, have actually almost mitigated or eliminated that disease. I don't think we want to go to that extreme, but I think we have to be much better at communicating the importance and sort of fighting against that misinformation. And in some ways that might be seen as paternalistic because we think we know better, but in some cases we may actually know better. We just have to be better at communicating that in a way that folks will embrace it and go along with it.
I know I'm supposed to be moderator, but I can't resist inserting something of substance as well. As many of you know, I've spent my life studying pharmaceuticals and use of pharmaceuticals. One of the things that has been clear for decades is passive education doesn't change behavior, even of physicians. Physicians are ineducable once they're done with medical school. They practice the way they learned in medical school and a house officer, and they spend the rest of their lives doing it. So education and communication is necessary, but not sufficient. It's interesting, Steve, you give the example of Australia where they made it mandatory as the one that's successful. So it's not just a question of giving information passively. Whether you use behavioral economics to motivate people, whether you do things from a mandatory point of view, we need to go beyond. Education is necessary but not sufficient in order to be able to change behavior. But other questions, Bob?
Should I say, I was given the microphone there just for a second. Nick Armenta, I work at Rutgers University Behavioral Health Care. I'm a psychologist, currently involved in running the state's drug abuse program that's funded by Medicaid and the state. But as a behavioral clinician, I've always felt like I've been a part of the group that's been the tail on the dog. And I never felt that the behavioral tail would wag that big healthcare dog. But hearing so many references to prevention and social determinants of illness and disease management and lifestyle disease management as well, I have a question, and that is, and certainly at-risk healthcare systems seem important to me, because as the pundits here certainly point out, that until that happens, I don't think we're going to have an effective healthcare system. But within that, do you see a role, a primary role, with all that said, for the behavioral professional in this? I mean, we're talking, most of the talk is about tertiary care, not prevention, not changing behavior, but primary delivery of, health care to those who are already ill. So do you see a role for the behavioral professionals like social workers and psychologists to address those lifestyle problems that will be essentially preventative, we hope?
Well, absolutely. One of the reasons why we have good HIV outcomes in New Jersey is that we have case managers and social workers and behavioralists associated with treatment. Because just providing a pill without recognition of all the other things that are going on in an individual's life is just insufficient. And so you're absolutely right that we need to go beyond the patient-doctor or patient-practitioner interaction to an interaction with someone who's going to help the patient have this new reality placed within a context. And so that's just to achieve good primary care. When it comes to prevention, it's even more important because we have to have a big lift of change in behavior. And how do we actually do that? Do we take out all elevators and have people walk upstairs? Or do we make better sidewalks? All these types of things are really behavior issues that need to be resolved with behaviors involved. So I think you're absolutely right that we are really short-sighted if we think that the only thing or the most sufficient thing is just the interaction between patient and provider.
Bob, Paul, and then we'll wind up.
So Bob Like again, Family Medicine, Robert Wood Johnson Med School. First, a quick comment, and this is a shout out to Dr. Blumenthal and the Commonwealth Fund. They published something on their website called the Charter on Professionalism for Healthcare Organizations, working with a number of hospital systems. And this is something we've actually shared with the Rutgers Health Group in terms of the importance of community partnerships, patient partnerships, organizational cultural change, and also paying attention to business practices. And so I think that that document really provides a very powerful framework for operationalizing a lot of the things that have been discussed today. The question I have, and I'm going to build on the idea of the tail wagging the dog, and I'm going to be the flea that bites the tail that wags the dog. And this is a question to the whole panel, which is your thoughts on how do we really eradicate prejudice, bias, and the isms in their various incarnations in healthcare systems. And the corollary to that is, what is the ROI for doing that? The business case, the economic case, the social case, and in fact, the moral case. It also takes us back to one of Eleanor Roosevelt's, one of my favorite quotes, is that we need to comfort the afflicted and afflict the comfortable. How do we do both?
I don't see the congressman rushing to answer that question. So I have what is probably a very naive answer to that. Certainly an organization like ours addresses those issues because there is structural racism in the provision of health care. There is unconscious bias, and we have attempted to educate ourselves and the 30+ thousand people that work in our system to try to make us better people. And I do think there's a moral imperative to do that. And I would only be, frankly, guessing or hypothesizing as to how that would affect society at a grander scale. But I will tell you, we've never looked for the ROI on that. I don't know that it's possible. I guess we could come up with a theory that says if people would act out of a moral base that is far enhanced from the one that we seem to be experiencing right now, it would make everything better, including the business case for an organization like ours. But you put your finger on something that has worried me. Organizations like ours have frequently stayed away from doing things that do not have an ROI because the popular mantra has been no margin, no mission. So if you can't make a margin, you can't pursue the mission. And while that is a clever phrase, it's actually been a barrier. So one of the things we are trying to do is break free of that. Candidly, Dr. Armenti, that's been the issue with behavioral health for a long time. It has been treated like a stepchild because no one's been able to prove, certainly in organizations like ours, that it makes a significant contribution to the bottom line. And yet, without supporting behavioral health, all the great investment in the other clinical care is far less effective than had we spent a greater allocation of our resources on behavioral health. So I think for us, the answer is we're going to do our best to address those things and not pay attention to some formal accounting of the ROI.
Just a quick comment, a couple of comments. I guess the first one is to get over our defensiveness. So every time somebody mentions isms, most people say, well, that's not me, that's, somebody else. I think we can all just acknowledge that we're all guilty at some point of thinking along those terms because it's all part of our society. And I guess in terms of what do we do, I would say lead by example, acknowledge that this is something that is a problem for all of us, and lead by example.
Right after the OJ trial, Steve Simmering and I wrote a book called The Race Trap, and it talked about how we are creatures of what we're used to. If we are raised in an all-black environment, that's what we feel comfortable with, and that's what we see as has a value. If we're raised in an all-white environment, that's what we're comfortable with, and then we have responses based on that experience. The answer to that is diversity. If you are raised in a more diverse environment, if you're educated in a more diverse environment, and educated by a more diverse population of teachers, then you're better able to respond to all those issues. And so at this university, that's been one of the things we have tried really hard to do. We've tried at both of our medical schools, we've tried throughout this university to make sure that we are diverse, and we are one of the most diverse universities, at least in the United States, and that is a good thing. Now, as far as the ROI, it depends on where you measure it. You can't measure it at the hospital level, but we know that if you measure it at the national level, you have better outcomes in minority populations in healthcare if they have been involved in treatments with people healthcare providers who've been trained in a diverse environment. And that's my answer to it. And I think it's something we do well. We have to continue to do it. It's not sufficient, and we're going to continue to move in that direction.
I would just say that, I mean, your question is kind of broad and probably would take an entire afternoon or several days to really answer. But I think that as opposed to looking at it in a moral sense, because it's very hard. I mean, you can talk to people at a moral level and say you should do the right thing and the humane thing, but a lot of times they just don't care, or they say they care, but they really don't. I just think that you have to, from a practical point of view, in other words, is say to people that, if you don't have diversity in your workforce, if you don't have diversity in your research, if you somehow exclude people from services within the healthcare sphere or sector, that's going to hurt everybody. Because, if you, for example, if you don't do research on whether a particular disease impacts African Americans, you may say, well, what do I care? I'm not African American. But we all know that that kind of research indicates very strongly impact on everybody, right? In other words, a lot of times we worry that we're not doing research or doing things to look at women's diseases or diseases that affect a particular racial or ethnic group. But then that kind of research is important for everybody because somehow it's going to relate. I always, my favorite thing was during the debate over the Affordable Care Act, the Democrats were very much, or I would say the more liberal Democrats were including myself, were very much in favor of saying that people who were undocumented should be included, right? Because otherwise, what's the point of having people who are undocumented not having insurance? They're just going to get sick. If they get disease, it's going to spread to the entire population. I mean, what are we talking about here? And yet we didn't include it because, everybody said, well, we can't include them because, that'll be a political problem, right? So, my argument was that doesn't make any sense because if someone's here and they get sick, they're going to make you sick. So I just think that maybe you can look at it at a practical point of view and say that having a diverse workforce, having diverse research, making sure that everybody's included and has access, certainly from a healthcare sector, makes practical sense. I don't know if I'm articulating it well, but it just really does. And I agree with you. I always make the example where I'm Italian American, right? And I sometimes I hate myself because I can't help on occasion, heralding the mafia or organized crime because they're tough and all this. You're in New Jersey. It's almost like the Italian American epitomizes the macho New Jersey tough guy, right? And then I realize that if I keep saying that, I'm creating this stereotype that makes people criminals or prone to criminality. And so you do have to constantly catch yourself too. It's a personal thing. I think that's what you're getting at because it's very easy. But on the other hand, if if you have a diverse friends, workforce, whatever, you start to realize you can't start making comments or thinking that way because it has negative connotations.
So there's a bunch of questions in the audience, but let me suggest people can approach the speakers afterwards because we're running out of time. So this concludes our panel discussion on the core challenges facing our health system nationally and here in New Jersey. First, I'd like to thank our keynote speaker, David Blumenthal, who was very generous sharing his time, his insights, and his wisdom with us this morning. Let me thank the panelists for participating this morning. Let me thank Jinshi Dong, Director of the Institute for Health, and each of the members of his organizing committee and our university staff for their time and contributions in bringing this event to fruition. As an academic health system that endeavors to serve the population of New Jersey, we clearly have our work cut out for us. climate change, medical breakthroughs, information technology, patient participation, just a few of the issues we've talked about this morning. Today is a celebration of Rutgers' historic partnership with RWJ-Barnabas, and so for final comments to wrap up this morning, I'd like to turn it over to Barry Ostrowski as President and CEO of RWJ-Barnabas for final comments.
Wow, I have to speak extemporaneously. Thank you, Brian. And I think we heard today all of the challenges that obviously our society faces and what some of the barriers are to really have serious positive impact on the problems. The thing that excites us at RWJ-Barnabas Health about this partnership is we have a partner that is culturally and philosophically aligned with addressing those issues regardless of what the challenges are. The intellectual capacity of Rutgers University and, of course, all of its scientific effort to date, together with our workforce and our institutions and our resources and assets, truly leaves me with a glass half full perspective on this. The challenges will make it exciting and interesting, but the outcomes will really be laudable. So we are celebrating this great partnership and can't wait to get on with business, and today is a perfect kickoff for that. So thank you all for being here. I appreciate it.
Leading this afternoon's group is Dr. Jinshi Dong, a geriatrician and director of our Institute for Healthcare Policy and, appropriately, Aging Research. Dr. Dong is our most recently recruited institute director, joining us earlier this year from Rush University Medical Center in Chicago. He is the inaugural Henry Rutgers Professor of Population Health Sciences and a member of the prestigious American Society for Clinical Investigation. He's a renowned population epidemiologist and health service researcher in the area of violence prevention, culture, and health disparities. He also chaired the committee that organized the symposia that today is the first day of. So let me introduce you to Jinshi Dong. And where did Jinshi go? Here he is. Thank you.
Good afternoon, everyone. I know we just had lunch. I know all of the gastric veins going into your stomach and your arms getting a little numb and you're falling asleep a little bit. Your heart rate is slowing down. Let me try this again. Good afternoon, everyone. Thank you very much. I'm really excited to be here. I want to thank Brian and Barry for this event and President Barchi as well. And when I think about, why healthy aging, and my role is really to get out of your way is to introduce the speakers, but the context is really important. As Brian said, not only geriatrician, but also issues healthy aging, what does that mean, and how do we link clinical care, education, and research into a singular platform. And really, I think in many ways we're at the forefront of many of those issues. When you think about those over the age of 65, from 46 million up to 98 million by year 2060, that a quarter of the population will be older adults. But also think about diversity, right? 78% of the Caucasian population will be down to 54%, 24% drop in terms of the majority group, and thinking about diversity inclusion issues for older adults. But also older adults are working longer as well. That 65 plus will be accounting for about 25% of the labor workforce amongst those older adults. So this issue is certainly close and dear to my heart, and we have three distinguished speakers this afternoon. The first is Dr. Jessica Israel, who is a practicing geriatrician and corporate chair of geriatrics RWJ-Barnabas Health. And since 2012, she has done multiple programs, Monmouth Health Center in Long Branch, and has established first outpatient palliative care programs in New Jersey and a national recognized geriatric medicine program. In 2015, Dr. Israel became the regional director of geriatrics and palliative care, expanding her program in Monmouth Medical Center in Southern Campus, where she developed service as director of the James Sharon Maida Geriatric Institute. Our second speaker is Dr. Carol Terragino, who is a professor of medicine and senior associate dean for education and associate dean for admissions at Robert Wood Johnson Medical School. She co-founded and co-directed 2 years patient-centered medical courses and director of clinical skill set center. She's won numerous awards, and she'll be teaching us this afternoon. Our third speaker is Dr. Soto Saraguchi, who is a member of the Institute for Health and also a pharmacoepidemiologist and a physician in the Center for Pharmacoepidemiology and Treatment Sciences in the Institute for Health. Combined with her clinical background, advanced training in epidemiology by statistics, she's published widely in the areas of comparative safety and effective medications and devices in patients with chronic diseases. Her article is being published in BMJ, Archives in Internal Medicine, as well as New England Journal of Medicine as well. And I think we're going to have each of the speakers in the order that I stated, and then afterward we're going to have the speakers come up as the panel and take some Q&As from there. So please join me and welcome our speakers. Thank you.
Thank you so much for having me today. I'm really excited to be here to present the clinical programs in geriatrics at RWJ-Barnabas Health, which have really gone through some wonderful changes in the last year. So let me start here. I always start with a story. I've used this slide before. This is me. I have no idea what's on my head. It's a weird hat that my parents put me in, but these are my grandparents. And everyone who does geriatrics, I think, has a place in their heart, someone that influenced them to do this kind of work, and these are the influencers for me. In particular, on the right is my grandmother, Mary, that I talk about a lot when I bring up geriatric issues. So she was a young mom of a son with cerebral palsy, and we're at a time where there were really no services for people like that. And she started the United Cerebral Palsy Organization in Philadelphia with the help of Eleanor Roosevelt, which is an incredible, incredible thing. And later in her life, she had Alzheimer's disease. And I was really struck by just that difference when she was in a hospital or in a nursing home setting, how no one really knew who she was. And a lot of the reason that I do geriatrics and a lot of the reason that so many of our colleagues in the system do is to have that opportunity to make a difference, to meet people where they are and to understand who they are. So this is a slide. Last year I was very lucky. I traveled to Copenhagen as part of the North American Aging Task Force to learn about how older adults are cared for in the Scandinavian countries. There are many things that they do better than we do here in the United States, and a lot of things that we can't exactly replicate, but there's a good amount of things that we can do. And one of the biggest principles I saw there demonstrated over and over again, which is the overriding theme to what we're doing in geriatrics through the system, is that our patients shouldn't need to find a way to fit into our system. We have to change what we do to fit our patients, and that's the overriding theme for all of the programs that we do clinically in geriatrics at RWJ-Barnabas Health. So I'm going to talk a little bit about an age-friendly healthcare system because that's what we're trying to create. I'm not going to go into a ton of details because I think Soku is going to talk a little bit about this later in her slides. But basically, an age-friendly healthcare system is really a vision of care for older adults. To just paraphrase this slide, many times what happens is that isolated programs occur in healthcare systems and they're never shared across borders to really make change. This one I will quasi-read because I think it's so important that nothing short of a social movement will enable us to address the growing number of older adults who need and will need person-centered, coordinated, location-appropriate care. I think this is so important because this is what RWJ-Barnabas Health is doing. We're creating a social movement with an emphasis on geriatrics to make a difference for patients in all of the places that we care for them. So just a little about what is an age-friendly healthcare system. An age-friendly healthcare system is a place where healthcare-related harms are drastically reduced or even approach zero, where older adults are satisfied with their care and they get the best care possible, where there's a leadership commitment to addressing ageism, reliable evidence-based care, staff that are specifically trained, high-performing healthcare teams focused on measurable outcomes, a real systemic approach to taking care of patients, their families, and their caregivers, and a process for eliciting patient goals in that process. how do we do this at RWJ-Barnabas Health? So I'm going to talk about a few of these evidence-based initiatives and some of the things we've done that are special to our system, and then focus a little bit at the end on some special projects. So we formed in the last year a geriatrics collaborative, and the collaborative has 2 to 3 members, interdisciplinary members from every hospital in our system. And we will be meeting in November for the 5th time to celebrate our 1-year anniversary. Over time, the collaborative has done some very special work. So I'll highlight one of our projects. We looked at how we take care of older adults with dementia and agitation across the system. And we looked at order sets and practices of physicians and providers in all of our hospitals and came up with one universal evidence-based way to care for these patients in an order set that we compiled together, which is now being put into the, I think, 3 medical records that we have across the system, and then eventually into the one that we'll have finalized. And that is a project that we did over the last year that I'm exceptionally proud of. I'm going to talk in a few minutes about some evidence-based geriatrics, nationally recognized programs that we're putting into place in all of our hospitals, and then I'll focus on some of our special projects. So many of you know what these programs are, but for those of you who don't, NICH is a program, nationally recognized program for nurses improving care for health system elders. We have 11 hospitals that are eligible for this certification. 9 of our hospitals are certified, and the last ones are coming on this month so that our whole system would be NICH certified. I think it's not a coincidence that one of our hospitals, Newark Beth Israel Medical Center, has the highest patient satisfaction scores in caring for older adults, and they have the highest level of certification in the NICH program, achieving exemplar status. So this is a program that's been shown to reduce many of the risks of hospitalization for older adults, and it's like a train-a-trainer program. The nurses are certified, and then they spread the word not just in areas of the hospital that are taking care of older adults that are known to take care of older adults, but other services. They go to the surgical floors, they go to the psychiatry floors, they go to places where older adults are going to get care and kind of spread the word. I just put this up here, I'm not going to read it, but another big accomplishment over the last year is that we brought together all of the system's NICH coordinators. We looked at every mission statement for NICH, and we came up with a universal RWJ Barnabas Health NICH mission statement. This is it here. And we, once our final hospitals come on as NICH certification, we'll be doing a system program with NICH. We're one of only a few hospital systems that will do that, working to improve geriatric care across the system. The HELP program is another program that we're putting into place in all of our hospitals. That is the Hospital Elder Life program. This is a delirium prevention program, and it's national and internationally recognized. And the really cool thing about HELP, which I think fits in so nicely with Rutgers, is that HELP is a volunteer-based program. So most of the people who volunteer for HELP programs are students, people who are interested in careers in healthcare, and it is a way for them to get valuable bedside experience, truly taking care of and touching people in the hospital. Many of HELP volunteers nationally go on to apply to medical school, they go to nursing school, they go to physical therapy programs. It's a pretty amazing program that has been shown to have a lot of wonderful functional outcomes. So it prevents delirium, it prevents functional decline of seniors, it can prevent cognitive decline while someone is in the hospital, it decreases the hospital length of stay, reduces nursing home placement, decrease the rate of falls, and decrease sitter use in the hospital. So a pretty useful program. And finally, in all of our hospitals, we're looking to institute something called JEDA. We love abbreviations in geriatrics. This is the Geriatrics Emergency Department Accreditation. So over the course of this year, we're going to accreditate all of our hospitals with this program as a unit, not separately, all with similar goals. The ED really sets the stage for geriatrics. When patients come to the hospital, it's the first point of contact most of the time. And I think it's amazing when you look at these statistics that older adults are 400 times more likely to need social services when they hit the ER than anyone else, right? So this is a program that recognizes which patients are really going to benefit from inpatient care and which ones really need effective outpatient care and services. So this is a little more about the Geriatrics Emergency Department Accreditation Program, ensuring that geriatric-focused education happens throughout the emergency room and that we use proven methods of care and proven order sets to make a difference, the right kinds of medications for patients who come in, the right kinds of services at the bedside. So a little bit about our special programs. This is me and our team when we opened the James and Sharon Maida Geriatrics Institute at Monmouth Medical Center Southern Campus. This is a very innovative interdisciplinary program that we're going to move throughout the RWJ Barnabas system. It's an outpatient-based program with a tiny inpatient piece. I'll describe that to you in a minute. This is a little bit about our program. This is our logo this is the intersection of a tree, in case you can't tell. And I counted the rings on this tree. This is a geriatrics tree. It's 68 years old, right? But I love that it has the different colors and even the scar. It makes an attempt to learn who our patients are. So part of the James and Sharon Maida Geriatrics Institute that makes it so special is that it's an inpatient program and an outpatient program, all contiguous in the same location. So a provider who's taking care of a patient as an outpatient can walk across the hallway to see them as an inpatient. Same thing, it's the same team taking care of patients. So we provide consultative and primary care geriatrics, consultative palliative care. We have a full-time audiologist. There's a rehab medicine gym that's shared by our inpatients and outpatients with physical therapy, occupational therapy, vestibular rehab, an amazing rock star social worker that does wonderful groups for our patients, 2 geriatric pharmacists on staff, and then the Better Health program. So the Better Health program, this is actually an old slide, but because now we have 2,068 members in just the last couple weeks in Ocean County alone in our Better Health program. So this is a free senior membership program that focuses on education and socialization to help seniors be more healthy. This is a great population of people kind of ready to, when we talk about preventative medicine and education, that's what this program does. We're very, very proud of it. It's at the heart of our Geriatrics Institute. We have programs on site and in the community every single day. It's not uncommon for me to wait for my patient to come out of yoga before they see me for primary care. It's a program that I'm very proud of. So now the technical piece, I'll show you a little bit more about our special projects. So this is House Calls Video Education Series. This is going to be incorporated into the Better Health app and also onto our websites. So we have various programs aimed to teach older adults in the community and their families about the issues that are facing our patients. There's an Alzheimer's House Call series, and this is just the trailer from the End of Life Education series. If it'll play, maybe. It's only like a minute, but if not, I'll go past it. There we go. Just play this for you. This is divided into 11, like 1.5-minute episodes.
October the 19th. 1987.
All right, the sound might not be good. Maybe we'll stop it.
However,
I'll just speak to it.
He saw more humor in things. I consider myself extremely lucky that I married the man that I did. I had a very good life with him.
He was a great dad. My kids really loved my dad. My dad really loved my kids. We don't even really know much about the cancer. Everything happened so quickly in the end.
So it's the day after a major snowstorm, and I'm heading to the house of a former patient of mine who died almost a year ago today. I'm gonna go meet with his family members to talk about his life and the end of his life, and hopefully to bring forth from that some lessons that other families can learn.
At the very end, we didn't talk about it.
I'm gonna have to stop it, so you get the idea. But these are minute to minute and 30-second clips with specific themes where you can measure what the viewer has learned, and there are lots of different ways to use these. We're embedding these in our website for the Institute and also available on handheld devices and iPods in the hospital. This is another interesting program that I'm just trying to focus on some special programs that we're adding to the evidence-based models that are going to be in all the systems. And this is a video-assisted pulse project. So the pulse, those are provider orders for life-sustaining treatment in the hospital. So this is a new project that we're going to do in 3 of our southern campus hospitals aimed at helping older adults tell us what really matters to them. When we look towards an age-friendly healthcare system, we look at what we call the 4 M's. We look at mentation, mobility, medication, and also what matters to older adults. What kind of care do they want? How do they want it delivered? Where do they want it delivered? This is another project that comes to the bedside and then populates our medical record with what those patients' wishes are. And I'll end just with the scary picture of me aged to 90 years old, right? And I put this up here because part of what we are doing in geriatrics is working to educate everyone that touches older adults in our system. So April 23rd of next year will be our system's first clinical geriatrics conference. And there are 2 main goals to that conference. One is that people experience geriatrics in a way that they never have before. And the second goal is that they leave that conference with the ability to do something they were never able to do before, or the ability to do that better. So it's a very, very interactive workshop, and in order to attend, we're going to age everyone on their ID. You have to be 80 years old to come to the conference. So people will recognize this is not just about someone's grandmother or the older woman that's down the hall in the last room on the left, but it's about all of us and the people that we are, the people that we're becoming, and the people that we love. So I encourage all of you to take this risk when you register for the conference, but to really make it personal. And I'll stop there so we can talk more about education and research in geriatrics, and I'll be happy to take questions later. Thank you.
I'm not quite ready to look like this, so. Good afternoon, everyone. So this is not just the future of academic medicine. This is going to be our future. We're going to be preparing our learners to adequately assess and meet the complex needs of the geriatric population. Today, I want to highlight programming that is currently going on in the undergraduate medical education curriculum. I'll demonstrate some potential manpower solutions to population health management that can maybe help you out a little bit, Jesse, in your programs. I want to show you that experiential learning is extraordinarily complex. There are a lot of barriers, but there are ways to get beyond these barriers. And probably the thing that I'm most passionate about is I really want to make the case that learners can add value and help transform a health system. So I share with you the fact that Robert Wood Johnson Medical School was one of 31 medical schools of all the schools in the country to be selected for a grant for accelerating change in medical education. Shereen Gabriel and I were both co-principal investigators on this grant, and I'll acknowledge colleagues that have been involved in this grant as I go through the rest of the presentation. The title of the program, Improving Chronic Illness Care and Population Health at Home, Maximizing Integrated Care Delivery Through Interprofessional Learner Teams. And actually, our curricular journey was chronicled in a monograph and was recently published, talking about how we're trying to improve the health system. Coincident with writing the grant, the Department of Health and Human Services really helped us to think about our project and to frame it, that we wanted to make this an interprofessional project. We wanted to do it within a coordinated care system, within an accountable care organization, and we wanted to profess the goals that we have to provide patient and family-centered care, to let our patients be confident in managing their health at home, and to make sure that our learners understood the complexity of patients managing multiple chronic conditions. The AMA grant were to develop provider skills in our learners so that they could engage and empower their patients to increase their health confidence so that they could manage their disease and stay healthy at home. We also wanted to make sure our learners understood the quality metrics that are used by an ACO, think about measuring them, and also strategizing on how to improve them. And finally, the third goal, which was probably over-ambitious on my part and rather lofty, I was hoping that our interprofessional learner teams would actually augment the home visit program that was happening within Robert Wood Johnson Partners, and that we could really make a difference and decrease hospitalizations and decrease costs. We are lucky enough to have our BHS, and our main collaborators in this program were the medical school at Robert Wood Johnson, the pharmacy school, the nursing school, the School of Social Work, and the School of Health Professions, the PA program. And Joyce Afrin sits on the Vice Chancellor for Interprofessional Education's team, and she was the one that really was able to engage the leaders of the other schools to put together these learner teams. We are lucky enough to have a patient-centered medicine course that runs throughout the 4 years of medical school. It is run now by Dr. Bob Like, who's in the audience, and Dr. Joyce Afrin, and we were able to have preparatory classroom discussions on geriatrics, end-of-life care, and palliative care. And I want to thank Fred Kovalars, who's sitting in the audience here, for bringing in one of his healthy patients and letting our students understand about the care of the elder patients. We also include in the patient-centered medicine series an experiential end-of-life experience. The students go out to these sessions, they have the opportunity to interview patients and clients there, and then as all of our students participate in guided reflective activities working with the elder population. Robert Wood Johnson Partners was incredibly helpful. We received the support of Dr. Al Talia, Dr. Josh Bershaw, Dr. Kathy Heath, the CMO, Dr. Kathy Dodsworth-Rugani, and nurse Jacqueline Plick. So we were able to make sure that our interprofessional learning teams were connected to the accountable care organization. So each of those very, very busy nurse care coordinators who were carrying 150 patients also had students on their teams to help follow these patients. And finally, as you know, we have a large cohort of elderly patients living in the state and living with multiple chronic conditions. The launch was complicated, very, very complicated and very hard to make interprofessional learner teams work together to make these home visits. Each of the teams included medical and at least one other profession, and the students would visit the patient for the first time with the care coordinator, and then they would set up and schedule independently their own visits with the patients and their families. So it was challenging. We had to come up with a HIPAA compliant platform that on which students could communicate, and of course all the students were not on the same electronic platform, so that was challenging. We needed to put team into this project, and I'll talk a little bit more about that later. The other thing that we needed to develop was a tracker, a way for our medical students to plan their visits and to highlight the accountable care organization quality metrics so the students could be sure to measure them. Faculty needed to be trained to understand what an SBAR node is, and for those who might not be familiar, it stands for Situation, Background, Assessment, and Recommendation, and it's a very efficient way of communicating information. Physicians weren't generally trained in this, and so we had to train our physicians to be able to read them, as well as read interprofessional collaborative care plans, which our students put together based on the patient needs. The other area that was challenging was that nurse care coordinators that were doing home visits weren't necessarily those who know a lot about academic medicine and teaching, so that we had to do some training of our nurses so they knew how to work with our students in the field. And finally, we had to identify a way that students could evaluate their patients' health confidence. I have to make a little detour and talk about the teamwork training and really brag about one of our medical students. He's now a fourth-year medical student. He's a former F-18 fighter pilot, and based on a reflection that he wrote to me in his first year, he said, "You know, Dr. T, the way these clinics function, there's really not a lot of synchronous activity, and it certainly doesn't match what happens in naval aviation." And Rick, being who he is, he identified team steps, and we brought a master trainer course to the medical school. We invited RBHS schools, interprofessional faculty, and staff from Robert Wood Johnson University Hospital. What I can tell you now is 100% of our medical students are trained in team steps in the beginning of the first year. We use the steps in team steps to, we operationalize them in that tracker I was describing, where students would write team responsibilities, talk about a brief and a debrief so that they learned how to practice real teamwork skills. And I would say that we've had a gradual understanding that teamwork training is really essential if you're going to have a high reliability organization. Here's an example of the tracker. So we really wanted our students to be able to do some goal setting with the patient and their family, ask the patient, what's one thing I can help you with? And it was a nice time for students to have rich interactions with the patients and their family. As you can see, we asked the students to perform some of the activities that would be measured in an ACO as quality metrics. They all did functional histories, fall risk assessment, and they even did a get up and go test. This was the tool that we used for measuring health confidence. For those of you that can't read this, the patient was asked, how confident are you that you can control and manage most of your health problems? And then there's the health information, how understandable and useful is the information that your doctors and nurses have provided to you. And so on each visit, the students would measure the patient's health confidence. So the results for those three aims. Regarding developing the provider skills, we adapted a survey from the Journal of Nursing Education to see if the students, see how they rated their confidence and the importance of things dealing with chronic illness, clinical skills, teamwork, and really understanding the health system. And in all of the items, importance was always greater than confidence, and that's probably appropriate for second-year medical students. But the highest confidence levels were in the impact of chronic disease and understanding the importance of interprofessional care, but the lowest confidence levels were learning anything about the health system, the ACO, or policy. And the narrative comments really showed that about 70% of students were satisfied with their patient care experience, but only 30% with the team experience. Regarding the chronic care metrics, 100% of our patients were screened for ADLs, activities for daily living. They had a fall risk assessment, medication reconciliation, screening for tobacco use, and blood pressure. So they're kind of useful when they're out there. And in about 50% of the cases, there was screening for independent activities of daily living, depression screening, and also about half of the patients got some cognitive screening. 100% of the students in an interprofessional fashion developed a collaborative care plan. And finally, regarding the health assessment scores from the patients, overall there were no changes. And I do have to say, having read all of the trackers, there were a lot of patients that had cognitive decline and were totally confident about everything their doctors told them, so we weren't really able to make much of that data. So here's my lofty goal: did we augment care? And so these medical students that went out to the house, and over 50% of times, they found something wrong with how the patient was taking their medicine. There were home safety hazards. Patient education was identified in almost 60% of the visits. New psychosocial concerns, new medical concerns. And every time one of these things happened, the medical student would contact the nurse care coordinator, so you can imagine how they love that among their 150 other patients having our students doing this. But I ask you, could the students have made a difference if we rolled this out large scale? And I wish Barry were here, because when he was a medical student for the day, our medical students talked about the project. And you know, our students acknowledged how dogs could make their patients so happy, but people that can't walk their dogs tend to have an uncleanly home because they can't do the dog walking. So our students arranged for dog walkers. And then there was this guy who just couldn't take his medicine or eat. And the students arranged for a dentist to make a home visit for this patient. So he got dentures. And this is just a quote from one of our care coordinators. Our patients really did appreciate the fact that the students were thorough and really supported them and really helped guide their care. So maybe we did make a little bit of a difference. There were challenges. Again, authentic interprofessional education is tough in a home setting. Scheduling, getting the students together with their very, very different competing school schedules. It was very difficult for our students to learn about health delivery, the delivery of health, because people were too busy. They were busy, and the care coordinators were busy, so day-to-day logistics really impacted that learning. It was hard to do the inter and interprofessional, as I mentioned, and I would say that the concept of value added was not the same for patients, care coordinators, medical students, and health systems. But I think we have some solutions. As everyone probably knows in the room, in academic year 1920, we'll be rolling out a new regional medical campus with a focus on primary care at Somerset Medical Center. And these students, there are 10 students in the pilot year, and they will be paired in a very authentic interprofessional environment, in that each patient will also have a nursing student and a pharmacy student. They will be able to focus on transitions of care and post-hospitalization continuity. We will continue our home visit program, but we will do it with second-year medical students outside of the care coordination program at Robert Wood Johnson Partners. The students will work directly with the patient's physicians. Finally, we need to identify a robust research agenda, and Shinshi, I'm hoping that's where you're going to be able to help us do the measurement for this, to see that we really are making the difference, because we've added this care. And I think we're well on our way to overcoming the barriers to teamwork training. Many of our residency programs have been trained, obstetrics trained, obstetricians, anesthesiologists, and nurses throughout the spectrum to deal with obstetric emergencies, and they have a robust research agenda going along with that. We're meeting with Andy Anderson soon to see if this can be something that can help us in our integrated practice, so we're moving it forward. So for our reflection, what strategies exist for addressing the not-so-hidden curriculum and dealing with resistance and inertia, so that we can really transform the institutional culture and habitus with a shared mental model? And how can different generations of learners figure out how to develop and sustain meaningful curricular and health system change? And finally, the AHQR has defined a learning health system, and how can we move toward this so that we can be identified as a learning health system? And I guess I want to read these 3 quotes to you, because I thought they really reflect where we're going. This is our future. These are our students' reflections about discharge planning. I think my familiarity and experience with the importance of the components to facilitate a successful acute care to rehab home transition have helped. Third-year students may sometimes feel like they have little to contribute when managing a patient's care, but knowledge of effective care coordination will allow any third-year student to be a valuable asset. About that elderly patient in hospice care and intractable pain, I haven't fully processed the lessons I've learned from her yet. I think she taught me more about the reality of hospital care. I still don't understand why she never made it to hospice, why she had to spend more time by me than by her family in her final weeks of life. When I think of her, I think of pain. Maybe after seeing more patients, I'll realize that this is the pain of metastatic cancer or the pain of impending death. I will never forget her pain, which I witnessed every day until postoperative day 39. My hope is that with time and experience, I will learn how to respond and care for this type of pain better, both for the patient and myself. And finally, about miscommunication leading to error in an elderly hospitalized patient. This experience in particular, and many others, continues to serve as a reminder of my passion and sincere desire to become an expert in health system science and focus on improving and developing innovations in healthcare service delivery. So regarding our future, I think it's quite bright indeed. Thank you.
Good afternoon. So my role here is to talk about clinical research, an age-friendly healthcare system. Before I dive into sort of introduce you to exciting research that's happening at Institute for Health, I'd like to bring us back to the core of what we're discussing, the patient. So I'm going to share a story first. It's about a 93-year-old Asian woman. She was married at age 16, and her whole life was dedicated to supporting her husband, who's 10 years older than she was. And her husband was a hardworking, honest man, but she was a typical Asian who disciplined her and her family. She devoted her whole life until her husband passed away at age 84, and she was 74. After a period of grief, she started embracing her new life with independence and freedom at her own home. However, as a typical elderly patient, she had multiple chronic issues. She also had pain issues as well. Her functional status declined, although she remained cognitively sharp. At one point, she had a fall at home that resulted in multiple vertebral fractures. And then she spent a few months in the hospital and then a couple months in the skilled nursing facility for rehabilitation. I have to say that she was taking multiple medications that also had a sedative effect on her, and then that might have resulted in this fall. Anyway, to her family's supply, she came back to home, and then she absolutely insisted that she doesn't want to be in the facility. Her son and then daughter offered to live with her in the home, but she didn't want to take it. However, she actually wanted to accept more frequent visits from her family members, as well as going to day services, maybe 3 times a week, to support her life at home. I went over details about the risks of being at home because she has a high risk of fall again or failure to thrive. This is what she said to me. I feel the happiest in my life with freedom, independence at home. I am perfectly content with my current situation with somewhat limited capacity. I am extremely thankful to my family for being left alone and cared and supported from distance. It is probably hard for you to understand, but this is the happiest life for me. So with that, I mean, this is one of the many stories of elderly patients that really speaks to what matters, which already Jesse introduced, 4 M's in the age-friendly healthcare system: medications, as this was something that resulted her into a fracture, mentation, and then mobility. So I'm gonna speak to each of these and then how this can sort of relate to research that we're doing. So again, the right-hand side from you is really the practice or definition of age-friendly health system. This is from the Institute for Healthcare Improvement. And again, this is something Jesse already introduced. So each sort of item, the feature that defines age-friendly health system, there is research behind it. The bottom line is really that evidence that is used to create age-friendly health system comes from clinical research. And then the process of developing such system, the clinical research can actually evaluate and feed back into the process of creating age-friendly health system. So starting from what matters, one of the 4 M's. Like Carol described, really the education is something that for each clinician to understand, get those skills to elicit what matters from the patients. But in the sort of a population-based level, it is a research to sort of provide you this information, what matters to older people, and then really support the population-level decision within the institute or in the policy to sort of allocate resources for what matters. And then based on this research published in the Archives of Internal Medicine, what older people value is really the independence, addressing pain, maintaining function, and then length of life really comes at the end. Now moving quickly through the next M, which is the mobility. So this age-friendly healthcare system should really address, help older patients to maintain mobility, function, and prevent and treat complications from immobility. So there are actually gaps exist in a clinical practice supporting mobility in elderly care. So this is an old study from 2001, but it shows that how infrequent we record mobility or functional status in the medical records. So looking at these numbers, up to 98% of the time, like information on one of the ADLs is missing. The most is recorded is walking, which is like 24% missing. So it's 75% recorded. The issue is probably multiple, but one of the issue is that the reason we fail to record functional assessment consistently, longitudinally, and comprehensively is the resource limitations, because we have to have someone who's trained to assess patients' functional status. So to address this, a team of researchers came up with an idea to use sensor-based technologies to measure physical function in a routine geriatric clinics. So this is a sensor that we can attach to wrists, maybe a waist or ankles. And then we wanted to incorporate this sensor-based measurement in the routine clinical visit so that we would have a consistent longitudinal measurements on the physical function in these patients. Of course, there are a lot of complications to be able to make this happen in a routine basis. So this is actually, we propose it as a preliminary sort of R21 that we're waiting, we're trying to work together. Of course, to be able to achieve this type of research, to develop infrastructure that is directly helpful for clinical practice, but also for research, because it's going to accumulate the data that we can use for research purposes. We had to pull together a lot of researchers in the interdisciplinary fields, including clinical epidemiology, kinesiology, computer science, informatics, and clinical geriatrics. And then most importantly, we had to approach to Jesse to be able to sort of collaborate, because we need patients to be recruited in this development process. And then we really want to develop a process that does not interfere clinical flow. And then we wanted to make sure that the data are accessible and clinically useful for clinicians. And I forgot to mention, but the goal is really to take this sensor-based data into the health IT infrastructure, and then really feed it back to clinical practice and research. So we also wanted to make sure, working with the clinicians, that geriatricians, nursing, and administrative staff support identification and enrollment of patients, and then really allow research staff to work with patients to test and establish this process and data collection. So this is really example of research that is really directly sort of feeding back to clinical sort of practice. And then really, as mentioned in the morning by David Blumenthal, that is this potentially be empowering patients as well, because expansion of this sort of way could be applied to home settings, inpatient settings, and potentially using their mobile phones, because there's a sensor already embedded in the mobile phones, really to provide information not only to the clinicians, but also back to patients as well. So the next M is the medication, and it's really core of what I'm doing as a researcher, and then Dr. Stromas has been doing as well. But medication has a lot of issue in the geriatric population, as indicated in the evidence from the clinical research, that they routinely do not receive necessary and evidence-based care, or are unnecessarily harmed by inappropriate medications. So how can you protect these vulnerable older adults from medication side effects and other insults? So the other M I wanted to mention here, because this Another fifth M that is often talked about in geriatrics is multi-complexity. So this speaks to the fact that a lot of elderly patients have multiple comorbidities, but not only that, they also have living conditions impacted by age, health conditions, and social concerns. But speaking of in a broader term, that is, we heard from this morning from, again, David Blumenthal, is climate change. So it's another environmental issue that impact older patients. As you know, heat waves impact more people than storms or other sort of environmental issues impact in the United States. And then in terms of air pollution, the things are improving in the US, but still more than a half of the people are living in the sort of quality that is not acceptable to health. So thinking of that, elderly population is really at risk for both because of immobility or because of the cognitive status. So what we're sort of proposing, and it looks like we're getting funded for this study, is to understand the interaction between medications and these climate factors, including heat waves and then air pollution, in terms of safety of the medications. Again, as a background, safety is a big issue in the elderly population because altered drug metabolism, they are often on multiple sort of medications called polypharmacy, and then again, inappropriate use of medications has been demonstrated in this population. So really, interactions between the comorbidities and polypharmacy, and then as well as heat waves and air pollution, because we know that that affects the cardiovascular or respiratory endpoints, it is very important to understand how these kind of play out together. This is a preliminary study that I conducted. So we were able to show, using large databases, pulling out Medicare data as well as the climate data together, that there was an increased risk of hospitalizations or all-cause mortality, 70% increase in the hospitalization, and then about 50% increase in mortality in the elderly population from heat, extreme heat. We also looked at the drug use in this population during the hot summer months. For example, ACE inhibitor is associated with a close to twofold increased risk of heat-related hospitalizations, and then stimulants used in this elderly population is associated with an 11-fold increased risk in the heat-related hospitalization. So there's enough sort of evidence to pursue this question. What we're planning to do here is to pull, as I said, large databases together from the climate science and the Medicare data and in the US population to understand this interaction between the climate and then medication safety issues. We're also collaborating with a population-based researchers in Taiwan using their population-based databases to do the same analysis. This actually may solve the fact that we don't have data on the air conditioning, whereas in Taiwan, the availability of air conditioning is much lower than what it is in the US. So the last one quickly is about the last four, which is mentation. We've heard about the importance of cognitive function in elderly patients, but also delirium is another risk that poses the quality of life not only the quality of life, but the prognosis of patient life in the elderly population. And then this often is actually induced by inappropriate use of medication. So this is what we're looking at in the Institute for Health, that we know that anticholinergic drugs cause delirium in the elderly population, but we actually don't know if it's true in the patient with dementia, especially most of them are using anti-dementia medication, which is supposed to interact the effect of anticholinergic medications and may potentially prevent delirium in this population. However, what we are finding currently is that they actually have similar or even more risk of delirium from this use of anticholinergic drugs, so they are not really protected by the use of anti-dementia medications. So really, hopefully, this is just a part of exciting research going at Rutgers, and hopefully I sort of convinced you that these sort of things feed into your practice of doing best care for elderly patients and creating age-friendly healthcare system, because you need evidence based on these such a quality study, and really sort of we have to create a feedback loop when you're creating something. You will have to evaluate, as Carol was talking about. We need to really work together to be able to evaluate what you're doing as well. And another thing I want to emphasize is that doing this type of research requires interdisciplinary collaboration among researchers and clinicians and educators. So really something, it's the theme of today's symposium. The last 2 points I would like to, for discussion, which I wasn't able to touch on in my presentation, which is how best disseminate the new or updated evidence from research into clinical practice. And the other thing is how medical education can foster next generation of clinical researchers and collaborations between clinicians and researchers. And thank you so much.
Thank you, panels. I think while we're getting the mic set, as many of you know, that IHI Institute for Healthcare Improvement is really poised and with their goals to set the framework for age-friendly healthcare system, at least 20% of them in the United States by the year 2020. And for those of you who may be interested, on Thursday, that Terry Fulmer, who is the president of Hartford Foundation, a colleague of mine, who's actually my original K-War mentor, is going to be giving a talk at the Institute for Health this Thursday at 12 noon for those of you who may want to attend. Perhaps we can open up the panel with perhaps interacting with each other, thinking about the questions that Soko posed to Jesse and Carol.
So yeah, the first question I posed was like how I can sort of work together to disseminate the evidence. For example, if I sort of did a study that showed that actually elderly patients who taking drug X has increased risk of heat-related hospitalization in the sort of under heat wave sort of circumstances, and then how that information will be helpful to clinicians and how we can sort of work together to prevent such event happening to these patients.
So I think that every time in the last year and a half since I've been in this role as the corporate chair of geriatrics, every time I sit down with someone new, there are so many ways that we can work together. And Soko and I have already worked together on the sensor project and the application for the grant. So I think that one of the ways clinically that we together can augment what is happening on the research front is really through our geriatrics collaborative. It is a great way to get a message out to all of our hospitals and all of our providers in geriatrics across multiple disciplines about what's happening in the system. So I think that's a good place to start. And then in listening to your work with medical students out in the community and really learning firsthand, that is another great way to change the future, because it's, I think someone referred to earlier, people remember what they learned in medical school and they kind of stay there. Wouldn't it be great for people to stay exactly where those comments were that you listed at the end? When I think about geriatrics, so much of it is about being human, right? I remember when I taught at Mount Sinai, we had a class called the Art and Science of Medicine, and we took 200 medical students and asked them to take their first history on patients in the hospital. I directed that course and I chose 200 inpatients, and I had a list in the hospital and I sent them out and I said, go ahead and take a history, but didn't teach them anything about what a typical medical history is. And what they did was they went out and they asked all these things that are so important about function, about family, about where you live, about what matters to you. And then we sent them back out again after we taught them that framework where you ask the chief complaint and you go through what we learn, and they came back really void of all of those details. So I think if medical students on the forefront can hold what they learned from those experiences, it'll make a very big difference as they go out into practice in all the different areas that they're going to concentrate in.
No, I just think we're not taking advantage of the fact that we have medical students, nursing students, NP students, social workers. We have all these professional students that need to learn, and there are things that they can do out in the field. And we can teach them, and we have all the benefits of education, but we could also move forward. We can move our system forward by sending them out. And it's really a matter of not having the infrastructure to manage these hundreds and thousands of students.
Just wanted to go back to what you mentioned, that they learn these great things and do great things in medical school. And you mentioned if they can keep that to the clinical practice until, and then there's actually in between is a residency and fellowship trainings. And really that's another sort of place that we haven't had a chance to discuss how we sort of align what we teach in medical school and then in the sort of residency, because that's where they actually acquire behavioral sort of patterns of what they do.
I think it's very infrequent that a resident is going to really know what happens to their patient when they go home, because they don't do anything at home. They just make disposition and that's it, and they never see that person again, and we really need to build that in to our training.
If there's a residency director or fellowship directors, we want to comment on this issue.
We'll take some questions from the field.
Yeah, I have a question. Dr. Terragino, you mentioned, how the assessments go for the geriatrics, and I was wondering, maybe it's embedded in your assessment, but is there an assessment of their alcohol use and substance use? Yes. Just a quick story. I used to work at the Center of Alcohol Studies many years ago, and one of the researchers did a study on alcoholism among the elderly, and the way they did it was they counted liquor bottles in the garbage cans in the senior citizens' villages, and it was influenced by whether or not there was a liquor store that would deliver. So, just wondering, do you do that assessment?
We do that. That is part of their assessment. That's a great question. I also noticed that when we do OSCEs, the objective structured clinical evaluations for medical students, frequently, if it's an elderly patient, they forget to ask about substance abuse. They don't think to do it, so it's a great teaching point.
Hi, I'm Padma Arvind. I have a general question for all the three of you. We work very closely with the many senior homes and assisted living facility, and often we hear from them that as people age, they tend to forget their acquired skills and languages, like especially when they go into dementia and Alzheimer's. And in that kind of patients, how do you work with them if they go back to their native language and cultural sensitivity? How do you handle those patients?
So you're asking when a patient has cognitive decline and goes back to maybe their native language or an earlier time in their life, how do you handle that? I think that that cultural sensitivity obviously comes into play there. There's a lot that you can learn even from the families of the patient that comes in. I think it's critically important to try to speak to patients in the language that they're speaking to you in, because so much would get lost in translation. But a lot of taking care of older adults with cognitive decline is trying to meet them where they are with what they're bringing into the room. All cases are different. So I think in that scenario, it really is, you look at everything that comes into the room with that patient, their family, what's happening outside of the hospital. It's very, very helpful to me to practice with a team of caregivers at the Institute. So there's a social worker who works with me, a nurse who works with me, a diabetes educator that works with me that would translate what that patient needs into where they are.
Again, Bob Like from Robert Wood Johnson Med School. First, congratulations to all of you on some marvelous programs. I don't have a question, but I wanted to make 4 comments. The first of them relates to the issue of how to communicate better, not only with doctors, but also with the public. And Dr. Terragino may want to speak about the work with the Alan Alda Institute because of the whole point of communicating science effectively, whether it's communicating science to each other, but also to patients. And so the video home recording things that you're developing, some of the research findings that were presented could easily, I think, be turned into brief YouTube or Vimeo clips that could then educate people in the community about that, as long as the people who do the research and the scientists and the clinicians can communicate effectively. So that's one piece that I wanted to throw out. The second comment was another one of the M&Ms, not morbidity and mortality, but would suggest considering meaningful relationships as another thing to be potentially measured, whether it's relationships with family, relationships with community supports, relationships with the system, relationships with work and each other, because I think the isolation or the lack of these authentic relationships can be a major cause for many of the other problems going on. The third comment I wanted to make relates to social determinants of health, and a project that the medical ICU at Robert Wood Johnson University Hospital has been involved in that was triggered by some of the intensivists there who were concerned with patients coming in with recurrent admissions, longer lengths of stay with COPD, with asthma, with diabetes, and finding out that a lot of it didn't really relate to issues in the hospital, but more issues out in the community. And so assessing not just social determinants of health in the community, but actually during hospital care, they're beginning to find that, in fact, it's not just vulnerable or impoverished populations, but actually older adults in some of the retirement communities who are coming in with sepsis and other conditions, and largely related to social determinants of health issues such as lack of transportation or financial insecurity or problems with utilities. We actually developed a mnemonic, those of you like Greek mythology, Theseus, who fought the Minotaur in the maze. Each of the letters is pregnant with meaning, the T for transportation, the H for housing, and I won't go through the rest, but interestingly, the hospital is integrating that into their data collection system and beginning to train people in the units, at least, to begin to address these issues. So I think that social determinants of health is another area for research and also for education. And the final comment, which will tie this in perhaps again to Mr. Ostrovsky's comments earlier, is investing in these sort of things, I think, help meet community benefit requirements under the ACA, so that if one is investing in community-based efforts with home visits or with education with communities and things of that sort, that can be reported to the IRS on Attachment H, Form 990, I believe it is. So I think there is a return on investment business case to be made for this.
Paul Weber. First to Dr. Sotoguchi, I wanted to add, in your research with the medications, are you including or considering phototoxicity and photosensitivity as part of increased interactions of medicine and you know, heat waves?
Sorry, could you?
Are you including the effects of photosensitivity and phototoxicity for medications within that research, or in the introduction or background to support that research? That's my first question.
Thank you. In the current proposal that is actually submitted to NIH already, and then looks like we're getting funded, that's not included. I think it's the issue of the data availability, that the data we have does not measure that.
Okay. And the second question is really to each of you, and that is, since we've focused more this afternoon on our learners, and we have now our next generation that's coming to be out to help support us and to help treat our patients and communities, what attribute or attributes do you see would be most important for them, since they are so solutions-oriented and socially oriented, to help really best position them for their future? For me, I often talk to students and tell them that initiative, enthusiasm, inquisitiveness are important, but what would you add to that to help guide them and maybe help them think about what's possible for them?
So my opinion would be the most important skill that an upcoming trainee or physician can have is good communication skills, is the ability to sit down with someone and see who they are and communicate the right way. These are very hard things to treat. Years ago, I did some research into what you can actually teach people and then what they actually learn. You know, there are skills that are much more kind of practice skills, sitting down when you're in a room. Touch is very hard if it's not something that comes natural to you, but you can teach those things. And the other part is in who that person is. So it's kind of bringing together both of those skills, something that's more practical and something that's more practiced to prepare somebody to get information from someone and to give it back. But I think that's the most important skill.
For me, I think it's reflective capacity. The ability to reflect both in action and on action. And I think that really works along with communication. To be an effective communicator, you need to be monitoring what's going on at the time. So for me, that would be the most important.
I wanted to go back to what you said. I think that also it's an important skill, but also sometimes go against the incentives or the paternalism that Dean Gabriel talked earlier. So system actually might have to help to foster that sort of feature. The other thing, from my clinical researcher perspective, I think another sort of connection that is lost, like we talked about earlier about the medical school to a clinical practitioner kind of connection, is between the connection between clinical practice and research. So for researchers who don't have a clinical context tend to kind of go on to pursue research for research, right? So that's really the, if you have own clinical context, that's great, that feeds you for that sort of aspect. If not, I think it's something personalizing sort of questions and then thinking about for patients, because we're doing clinical research, I think that's something that very important for clinical researchers.
Other questions people may have? Fred?
Yeah, hi, Fred Kobolars, geriatrician here at Robert Wood Johnson Medical School. Just a comment, you brought up the issue. I know we focused here a lot on medical schools, but the training, continues through residency. There are competencies that are required for, residents that are doing family medicine training for internal medicine in geriatrics. We also do have a fellowship here in geriatrics at the medical school. So after you've completed medical school, you've done your 3 years of residency, you can actually do a 1 year of geriatric training to become specialized in geriatrics. So I think that the training is just not limited to the medical student, kind of exists across really all specialties. I don't care, what specialty you're going to, be doing, gynecology, pediatrics. You're going to have to, these core principles that we're talking about, communication, function, medications, whether, little, grandma's bringing in little, baby. I mean, you're going to be encountering older adults, in whatever specialty. So I think it's, it's really, very key.
I'd just like to comment. So what do you all think we need to do to increase the proportion of geriatricians in the workforce?
So this is obviously something that the field struggles with because we have a national shortage of geriatricians. So a lot of us look to how can other people get involved, especially because right now we don't have enough to meet that need. But I think that that encouraging people to go into geriatrics comes from what they're exposed to. I think that a healthcare system that really is dedicated through clinical work, through education and through research to create an age-friendly healthcare system and expose our students, our patients, our residents, our fellows, and our colleagues to this is a place that would foster the exposure
that would make someone open their eyes and say, maybe this is something I should do. That being said, it's not something that's going to be solved tomorrow. So programs like some of the programs that I described, in particular Niche, reaches into the nursing community to grab nursing leaders who are interested in geriatrics care. Programs like HELP reach into students, reach into a community to grab people who are interested, and then to create a larger amount of people working towards the same goal, to, in a way, counterbalance the shortage of geriatricians and people in that field.
Just wanted to say, I totally agree that we need more geriatricians, but at the same time, it probably does not solve a problem. For example, the case I described, the medication, the sedative medication prescribed to the patient was done by orthopedic surgeon, not by her geriatrician. So really not that, educating, having more geriatrician doesn't solve that whole problem. And I think we need to educate, like again, in the medical school to continuously in the residency program in surgery or medicine to really support this age-friendly healthcare system.
Sounds like you're setting up an elective for our medical students at your center.
And to that point, if you read, imagine not bringing your children to a pediatrician, right? Yeah, we're bringing our aging parents and grandparents to non-geriatricians. There's nothing wrong with that if the care can be met at the same time. That if you read the IOM seminal book, Retooling the Aging Workforce, and really talking about how do we use geriatric principles to infect other disciplines. And there are many scholarships and fellowships aimed to do that, ranging from GEMSTAR to MSTAR to Butler-Williams program. There are many programs out there that actually incentivize subspecialties to actually learn some of those geriatric principles that we're talking about.
I actually work a lot on workforce development. So I think geriatricians, it is not only with those people, only with professionals and physicians that we are talking about. I think geriatric specialty, we need to address at all different levels, right? And even the social workers, health educators, and patient navigators, and every level people communicating with the aging population. It is kind of very different from communicating with adults and young adults and pediatricians. And that is what that we were told when we talk to aging population or when we work with living assisted facility or senior home. And that is the workforce that we are currently developing. I mean, training program with curriculum development, talking to people about bringing out different certification program in bringing out that extraordinary skills. Yes, we do need geriatricians at the physician level, but I do think that we do need nurses and nurse practitioners and also patient navigators, community healthcare workers at every level, that we need people who have specialized skills to talk to geriatric population. Because the way that you talk to them, the way that you work with them, the way somebody who has dementia or Alzheimer's, who has cognitive disability is totally different than how you talk to people who have normal capabilities. So I think we needed to focus on a whole lot of different spectrum of workforce development rather than one single workforce program. Thank you.
So I think that's a great comment. I think medicine is always better when it's with a team. The different perspectives that disciplines bring to the care of a patient and putting that all together in a comprehensive plan is always better than what one person can do alone.
Hi. Les Barter with Ernest Mario School of Pharmacy. I'm the Director of Simulation. Two comments, more than anything. One, I applaud the efforts today, and I appreciate all the information that came in. And sitting here, I just seem to recognize that there's a lot of research being done that maybe we can break down some of the silos. Some of the research that you have in your geriatrics through your research there in the app, maybe we can tie into things like the activity tracking and really get that data to talk. And when we talk about interprofessional and collaboration, getting that in to really yield better results out of it. The other side is interprofessional education-wise. From the School of Pharmacy, we do simulations, and we're trying to get more into that interprofessional connection, and communication is absolutely key, so I applaud you for that too.
There are 3 pharmacists in our system that are members of our geriatrics collaborative that are that were really important in building the order set for delirium, and also really important in educating our committee and bringing that back to the clinical care in our hospitals. They're all geriatric certified pharmacists. I'm lucky enough that there are 2 that are members of my care team at the Southern campus and sit down with patients and do medication reviews in the emergency room, in our outpatient practice, and do for larger groups in our Better Health Education program. It makes a very big difference. I think the more disciplines you have around the table in caring for someone, the better that care that will be.
We'll take last question. Any takers? Okay, if that's the case, thank you very much. Please join me thanking the distinguished panels. Brian, any lasting words?
Rather than wait for me to get upstairs. So thank you, everybody. Thank you, Jinshi, for organizing this. Thank you to the committee. Thank you to the panelists for your great comments and time. Thank you all the audience for sticking it out. It's a long day accordingly. This is a foreshadowing. Jinshi chairs a committee that has had, as I alluded to before, multiple other sessions planned in the future. One on global health, one on behavioral health, and one on cancer. Thank you. And so I look for the announcements. You'll see them forthcoming, and we'll have other such symposia in the future. So thank you all, and most of all, thank you to our partners from RWJ Barnabas Health. This is really, as I alluded to from the beginning and throughout it, really the beginning of a wonderful partnership, working together, clinical care academics together to build one of the best academic health centers in the country. Thank you.